Good evening, Reena ma'am.
Good evening, Shruti. Good evening to everyone here.
Good evening, ma'am.
Chalu ma'am, good evening.
Good evening, good evening. Am I audible?
Yeah, ma'am, absolutely.
Okay.
Crystal clear.
Reena ma'am, how are you?
Very well, thank you. Thank you so much. How are you doing? Thank you for being here today with us. Thank you so much.
We'll just wait for a couple of minutes because I'm just checking with the Anil sir, Anil Dikru sir, if he's able to join. Saishav sir, good evening.
Good evening.
Dushyant sir, good evening. Sunil sir, good evening.
Hello, good afternoon. Good evening.
Good evening.
Good evening, madam.
Good evening, sir. Prashant sir, good evening.
Hi, good evening. Yeah, am I audible?
Yes, sir, absolutely.
Yeah.
Ramesh sir, have you joined us?
Is this the meeting?
Yes, that's right.
Thanks.
Rakesh sir, Rakesh sir, have you
Is
joined
it
us?
the inauguration now?
Yeah. Yeah, sir. This is Deepak sir, right? Dr. Deepak sir?
Yeah.
Yeah, so we're just starting in a minute. I'm just checking with Dr. Somesh and Dr. Anil. They have not joined.
Yeah, I'm here. Shruti, we can't hear you. No, we can't hear you.
Sir, actually, I was just speaking to Dr. Somesh, sir. That's why I just kept myself on mute. Thank you.
Yeah, thanks. Yeah.
Yeah, there's some connection issue. He's trying to join, and I'm just checking for Dr. Rakesh. Dr. Rakesh, sir, are you there with us? Not joined yet. I can't see him. Good evening, Dr. Ranjita. I'm just absolutely sorry for this delay. It's just that our dignitaries for the inaugural ceremony are trying to join in. There's some technical issue. Just a 2 more minutes and then we start. I'm extremely sorry for this delay. Arvind sir, good evening.
Good evening.
Ranjita ma'am, good evening. Thank you for joining in. Lalita ma'am, good evening.
Yeah, good evening, ma.
खाना तो नीचे ले आया था अंदर रखा है वहां पे
Can I request all the other participants to please be on mute? Meenu ma'am, good evening. I can see you. You're there. Meenu ma'am.
Hi, good evening.
Ma'am, how are you?
I'm fine. How are you, Shruti?
Ma'am, we are good. We can't see you.
Can you see me now?
Yeah, absolutely now. Dashing and gorgeous as always.
Thank you so much. And I must say, hats off to efforts of the entire team. I can already see there is a huge gathering, 80 plus people who have joined. That's a very good initiative.
Thank you so much, ma'am. I think there'll be still a lot more joining in because we already have 750 registrations till date. The link of joining has gone. The team is already connecting with them to join, just as a reminder. So I'm sure that at least we should have a good gathering today for the event.
Great. And actually, congratulations to the entire team.
Sorry, ma'am, I didn't get it.
I said congratulations to the entire team.
Gee, thank you so much, ma'am. Thank you so much.
Good evening, Dr. Meenu. Nice to see you.
Hi, good evening. Kaise ho, ma'am? How are you?
Bilkul theek hu. First class. Thank
After
you,
a
sir.
very long time.
We are meeting after a long time. Yes.
Rakesh sir, have you joined us? Rakesh sir, I still can't see you. Somesh sir, have you joined us? It's already 3:08. Yeah, Dr. Imran, you want to say something? You've raised your hand. Yeah, Rakesh sir. Good evening, Rakesh sir. He's joined us. We're just missing Somesh sir, I think, and then we should start. Somesh sir, are you there with us? Dr. Karpa, good evening. Welcome. Dr. Parmesh, good evening. Dr. Arul, good evening.
Good afternoon, ma'am.
Sir, good afternoon.
Ma'am, how to set the background, ma'am?
So you see over stop video, now there's a small V, inverted V icon there. Just click on that and go to choose virtual background.
Where, ma'am? In the top of this Zoom meeting is there? Z.
Yeah. Over stop video, there's a button now. Stop video towards the below left, bottom left corner. See the bottom left corner of your screen.
Shruti, I'll just call in. Arul, I'll call you.
Yeah.
Okay, ma'am.
Somesh is joining in, and once he joins us, we'll start. I'm absolutely sorry for this delay. We're 10 minutes late. But we'll try to be fast and cover up the lost time in.
Yes, ma'am. Good afternoon, ma'am. Yes, ma'am.
Okay, we have Somesh. Sir, Somesh, welcome. Good evening.
Good evening. Can you hear me?
Yes, sir, absolutely.
Thank you.
Just can't see you. Yeah, now we can see you, sir. Thank you so much.
Thank you.
I'll share my screen now and we'll begin the session. Warm good evening, everyone. Thank you so much for joining this wonderful third season of the ICanCaRe International Oral Cancer E-Conclave. Heartfelt thanks to the organizing committee for making this successful for the third year in a row. I'm very happy to say that this year the theme, after we did the first year with intrigues of oral cancer, last year we did on capacity building for oral cancer. This year the theme is do it, but do it right. The main focus, the main intention that whatever we are doing, that should be directed towards enhancing quality of life in patients so that they do not have to face much difficulty and win over cancer very successfully, have a beautiful life beyond cancer, and ensure that they're able to overcome each and every problem very successfully. I thank all the partnering organizations who have been working in the background to make this event a huge success. This time, we also have Telemedicine Society of India joining us, along with the Federation for Head and Neck Oncology, Sterling Cancer Hospital, and Gujarat University, along with ICanCaRe. These are our dignitaries of the evening, and I'm very, very thankful for that I have this opportunity to introduce all the dignitaries of the evening one more time to you. Our Chief Patron, Dr. Anil Dicruz, Director of Apollo Cancer Hospital, Dr. Himanshu Pandya, Chief Patron, also the Vice Chancellor of Gujarat University, our patron, Dr. Somesh Chandra, Director of Sterling Cancer Hospital, Dr. Alok Thakkar, the Executive Member of the Governing Council of FHNO, Dr. Prathamesh Pai, President of the FHNO, Dr. Rakesh Rawal from Gujarat University, the Coordinator for Certified Tobacco Cessation Courses, Dr. Meenu Walia, Medical Oncologist and Senior Director at Max Institute of Cancer Care, our convener, Dr. Pavan Gupta, and also founder of ICanCaRe, our Academic Director, Dr. Reena R. Kumar, co-convener, Dr. Manoj Tayal from Radiation Oncology Max Super Specialty Hospital, Dr. Tapaswini Pradhan, also Senior Consultant Head for Head and Neck Oncology from Indraprasth Apollo Hospital. Thanks to Dr. I'm absolutely honored to also introduce to you our lead organizers for the evening, Dr. Dushyant Mandlik, Treasurer of FHNO, Dr. Arun P, Secretary of the FHNO, myself, your host for the evening, Shruti, Rishabh, who is the Director at ICanCaRe, Dr. Ranjita, and Dr. Harshita, our clinical experts at ICanCaRe. Thanks to all the organizers, Dr. Aruna, Dr. Durga, Dr. Rajkumari, Dr. Anshul, Dr. Vijay Lakshmi, Dr. Manisha, Mrs. Sonal Bhatia, and Dr. Pravesh Singh, who have been tirelessly working to make this event really successful. And now I invite our Academic Director, Reena ma'am, to quickly welcome the guests.
Thank you so much, Shruti. A warm good evening, ladies and gentlemen. In this month of April, as we dedicate this to the oral cancer awareness, and of course, as Shruti just told you, this is for do it, but do it right. And this is our third edition of the ICanCaRe International Oral Cancer E-Conclave. I extend a very warm welcome to our dignitaries on and off the virtual dais. I thank and welcome our patrons for their constant support and motivation. And of course, our chairpersons, the organizing chairpersons, and the entire organizing team who have been relentlessly helping us to put this together. A warm welcome to our domain experts who have joined us as chairpersons, faculty, moderators, and our quiz master. My heartfelt welcome to our audience for their overwhelming support. It is your support. Today we have nearly 800 registrations plus, and your presence truly encourages us and makes us know, yes, we are there and we are doing it right. So wishing you all a very an evening which is full of scientific knowledge sharing and deliberations. Over to you, Shruti.
Thank you so much, ma'am. And now we move towards the digital lighting of the lamp.
Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah. Shatrubuddhi vinashaya dipajyotirnamostute. Dipajyotirnamostute. Shubham kurutvam kalyanam arogyam dhanasampadah. Shubham kurutvam kalyanam arogyam dhanasampadah.
Now I'll invite Somesh sir to kindly inaugurate the E-Conclave. So I'm giving you the remote control. I'll request if you can just press the inaugurate button and we'll be able to start the, virtually inaugurate the session. So you have the remote control to my desktop.
Okay.
Big round of applause to all the from all the audience that we have inaugurated the virtual inaugurated the E-Conclave virtually. And now I'll invite Somesh himself. He is the director of head surgical of oncology from Sterling Cancer Hospital Specialty Clinics and Cancer Center. Sir is a proficient and a very terrific oncosurgeon, and I invite him to talk about this theme, do it but do it right. What does it mean and what does it demand?
Thank you, Shruti, and welcome all to this third edition of E-Cancer Conclave. We had two previous successful editions, and despite the fact that in-person meetings have started, it is very heartening to note that there are over 800 registrations for this meeting as well. The meeting has evolved in structure and usefulness over the past years. The theme this year, do it, but do it right. Basically, there is a saying that what we have to learn to do, we learn by doing. So every time we do it, we have to do it right. Otherwise, we learn the wrong things. And that precisely is what we are going to discuss in this meeting with the help of expert faculties of how to do things right. A lot needs to be done, and obviously we need a lot of hands to do it. But not doing it rightly is worse than not doing it at all. So with those words, I invite all the faculties and participants to get on with the scientific discourse. Thank you.
Thank you so much, sir. Rightly said that we need a lot of hands to actually manage and take care of oral cancer, which is the king of cancers in the country. And now I invite Dr. Prathamesh, sir. Sadly, he's not with us today due to a very sad event at his home, personal emergencies at home. So on his behalf, I would like to invite Dr. Dushan Mandlik. Sir is the treasurer of Foundation for Head and Neck Oncology. He's also one of the terrific oncosurgeons which we have with us on board. Can I kindly request all the participants to please be on mute? Thank you. So his expertise lies in surgical management, and his special interests are in oral cavity surgery and reconstructive surgeries following head and neck cancer surgeries, which is essential not only for cosmosis but also for functional rehabilitations of the tissues. So now I invite sir to quickly talk about why IFHN is collaborating for the cause and how to actually make it right.
Good evening, Shruti. Good evening, everybody. And special thanks to ICanCaRe.
Can I request Dr. Balram, can you please be on mute? Sorry, yeah. Sir, please go ahead.
Special thanks to Dr. Pawan, Dr. Reena, and ICanCaRe for this meeting. On behalf of the Foundation of Head and Neck Oncology, we are welcoming you to this third edition of ICanCaRe, which is an oral e-conclave. As there are three main thrusts of activities for Foundation for Head and Neck Oncologists, and they are promoting research programs in basic science as well as clinical areas, initiating educational activities, and cancer prevention and structured oncological training programs and fellowships in head and neck oncology. So cancer prevention, and especially oral cancer prevention, is the utmost important agenda for our part of the world. And we are happy that with FHNO and ICanCaRe, for the consecutive third times, we are going to do that, and in a well-structured and well-planned manner, which will help a lot for the cause in the future also. Thank you.
Thank you so much, sir. Very rightly said that it is a part, and this is the third edition, brings in a lot more knowledge to be given to all the healthcare professionals who are there with us. Now, I take this privilege to invite Dr. Rakesh Rawal, the Professor of Life Sciences from Department of Life Sciences of Gujarat University, also the coordinator for the tobacco cessation specialist courses. Sir, kindly address on the need of the university intervention for oral cancer control. Sir, over to you. Sir, we can't hear you. You're on mute.
Am I audible now?
Yeah, sir, absolutely.
Okay, so on behalf of Gujarat University, I welcome you all to this third oral cancer conclave. And as Shruti rightly told, that Gujarat University is instrumental in endorsing several courses which were proposed by ICanCaRe. Those are all on tobacco cessation. And we are looking for more research collaboration with the various stakeholders of ICanCaRe, those who join this course. And that will be through a network of all the participants, those who are tobacco cessation specialists or the tobacco marshals. So the next focus is on salivary-based biomarker detection for early diagnosis and screening of large mass of cancer cases to decrease the burden of oral cancer. At the same time, we are also looking for the intraoral camera-based detection of these early lesions, because these cases, they reach to the dentist or the oral healthcare professionals first as compared to cancer specialists. So just with the help of imaging, using the AI/ML based detection, if we can catch them early, that will indirectly decrease the burden. So these are the new avenues where we all are working. And I welcome you all to this conclave once again. Thank you.
Thank you so much, sir. I'm sure that our participants and our guests from different parts of the country would be very willing to join us in this network, bring out that change, and to play a major role in early detection of cancers in the country. I now take this privilege to invite Dr. Meenu Walia. Ma'am is a senior director and head of Department of Medical Oncology at Max Institute of Cancer Care. She's a versatile woman. What I can say is she's just known everywhere. She's known for her joyous nature and prolific treatment. She has been awarded with Inspiring Healthcare Leaders Dronacharya Award by the Honorable Minister of State and Health and Family Welfare, Government of India. She was also conferred with the Certificate of Excellence at National Healthcare Conclave by late Sri Anand Kumar, who was the former Union Minister of the Parliamentary Affairs. I now invite ma'am to talk about why we have this Oral Oncology Connect. What is the need for wider collaboration and to reach out the audiences?
Thank you, Shruti, first for a very warm introduction. And before I begin, I must compliment the entire ICanCaRe team for such an initiative and such a consistent efforts which is really making a lot of difference to the society. So coming to the next question, why this is important, we all know that oral cancers have now become are actually a public health problem in our country. So they have been head and neck cancers have always been a major public health problem, have been a major problem in the Indian subcontinent, accounting for almost they are almost the leading cancers in our country. And as per ICMR, we know that it attributes approximately 27.3% of all cancers related to tobacco. And the number doesn't seem to be going any less in the near future. So what is the need of the hour? The need of the hour is action. And unless that action is taken, it is already late, and it may become so late that beyond repair also. And while we talk about this oral connect, we all know that without collaboration, nothing happens. And that is why all the important members in the patient's journey need to be connected with each other so that we can give best results, best outcomes to our patients. So dentists are a very, very important part. Rather, they are the first connect in the patient's journey of all these oral cancers. So joining hands with our dental colleagues, joining hands with the oncologists, and joining hands across the various specialities of oncology and even palliative care, it makes a lot of sense. So this cooperation, joining hands, connection, that is the basis of a strong foundation, and that is what is the need of the hour. And with that, I will rather welcome everybody and look forward to a very interesting discussions in the coming days. And I hope that we are all enlightened and have new learnings from the coming sessions and upcoming sessions. And with that, I welcome everybody. Thank you so much.
Thank you so much, ma'am. Very rightly said that it is all about action and everything about taking actions at the right time and doing it really, really right. It's now time that I invite our dearest academic director, Reena ma'am, to talk about the ICanCaRe perspective. How do we tame the oral cancers in India?
Thank you, Shruti. Thank you, Dr. Meenu, for a very lovely, initiation into what we're really looking to do. So we all know that this is the king of cancers in India, the oral cancer, and with the kind of tobacco use that we have in our country, whether it is smoking, smokeless, or the smokeless, or the secondhand smoke, the use of alcohol magnifies all this risk. And we all are aware that the average 5-year survival rate of this oral and oropharyngeal cancers is about 65–68%. But this mortality, if we diagnose it early, the mortality is very high. But if we diagnose it early, and we do not allow it to reach it to the advanced stage, we can actually do a lot. So yes, the theme of today's is definitely early diagnosis is vital. But then we at ICanCaRe believe that, there is a multi-pronged approach that we need to take to work towards this. Being an academy. We believe in education is our strength. So there is education. I will talk about that. We have capacity building because we need to do that. We need to create advocacy for empowerment of the population and assist while we are working to save the youth, educate the women, save the families. So our approach basically to tame the king of oral cancer would be to create capacity building, which would be through education. Like there is a gap and a need for healthcare workers who are actually healthcare professionals who are trained to do a scientific methodology for tobacco cessation. And we at ICanCaRe are very fortunate, and we are thankful to Dr. Rakesh Raval and to Gujarat University that we have been given accredited courses, that is the orientation course in tobacco cessation and the certified tobacco cessation course. We are fortunate to have had 432 doctors of different specialities who have been trained in the OCTC or the orientation course. And we have 142 doctors from different specialities again who are trained to be certified tobacco cessation, full-blown certification program they have done, and they are the certified tobacco cessation specialists, and many of them are already set up their tobacco cessation clinics. While we are looking at, the tobacco control in the society through the foot soldiers, which is our tobacco marshals. So anybody who has a passion in the mind, there is, who wants to work towards, is empowered with the knowledge about tobacco, about the Kotpa and Panpas rules, and these become the immediate marshals and they become the immediate foot soldiers on ground, working to create awareness, advocacy, and at the same time, these are the people who are, empowering the users, empowering the families, saving the youth, educating the women, and we are going on. So we at ICanCaRe have created 1,024 marshals and large number of mini marshals. So that is our part of the program, while we are providing a dedicated quit line so that anybody can reach us, at any point of time. There is education on the campus. There is happening. You can see what is happening with these webinars and our E-Conclaves happening around the year. And of course, we have quit coaches. We have an ICanCaRe wellness app, which is our digital technology is the way to go. And of course, the virtual clinics, which provides the ability for our patients, our doctors to meet on one single platform in different languages. It does not matter. There's no barriers here. So at ICanCaRe, taming the king of oral cancers is not an easy task. And we have taken this very multi-pronged approach. And we thank Gujarat University once again for believing in us and helping us. And we just heard Dr. Rakesh telling us that how we are going to be working towards biomarkers and looking at AI/ML and how we're going to include this all in early diagnosis. Thank you so much. And I wish you all a very happy learning and deliberations. And I'm sure we'll all take back lots over this 4-week sessions. Thank you, Shruti.
Thank you so much, man. I'm sure our audience is highly enlightened, and I'm sure that a lot more of our healthcare professionals would love to join our hands together at the ICanCaRe family and really participate into early diagnosis and doing things right. So on behalf of Dr. Himanshu Pandya, we had Dr. Rakesh Raval addressing his note. Again, on behalf of Dr. Anil D'Cruz, I would like to say he's passed on this message that we're doing a great job, and together we have to really make things right so that we can tame the king of oral cancers in the country. So we thank sir for his beautiful message. And he has also said that he's a staunch supporter of the ICanCaRe initiatives. And he thanks us for this sustained and continued initiative to ensure that we are actually working towards ground level enforcement, treatment, and management of this deadly disease. I would now like to propose vote of thanks on behalf of Dr. Arun P. So I would like to thank all our dignitaries who have been here today with us at the inaugural ceremony. Thank you so much for participating at the event. I thank Dr. Anil D'Cruz, Dr. Himanshu Pandya, Dr. Alok Thakkar, Dr. Somesh Chandra, Dr. Rakesh Raval, Dr. Prathamesh Pai, Dr. Meenu Walia, our academic director Reena ma'am, Dr. Dushyant Mandlik, and all our lovely audiences here to really make this event successful. Thanks to all the participating organizations who are working tirelessly with us, constantly supporting us in all our initiatives to ensure that we are working towards the right cause and we are ensuring that everything is possible to do it right when we have synergy and collaborations and hands to join together to take action at the right time. Thank you to all the audience who are there with us on Zoom, on YouTube and Facebook, who are also connected and would love to take the initiatives ahead. Thank you so much for being a part of the session today. I would now like to take the session ahead, because now the inauguration ceremony is over. So I would like to just say that stay tuned, because we have wonderful quiz competition and the student paper presentation competition upcoming after the scientific sessions are over. So we're going to announce about what these are and how it is going to be very shortly. We now move towards the scientific sessions for the day. We have 5 sessions in total, and the theme for the day is diagnosing oral lesions and treating them right. I now invite the moderator for the scientific session, Dr. Durga, who is professor in oral medicine and radiology from Sri Rajiv Gandhi College, Bangalore. Kindly take over the chair. Her areas of interest include tobacco cessation, oral cancer, salivary biomarkers for early diagnosis of oral potentially malignant disorders. She's presently the professor there. She has also done a fellowship in forensic oncology from same college, and I request her to take the session ahead. Thank you so much.
Good afternoon to one and all. Am I audible?
Yeah, you are.
Okay. It gives me immense delight to introduce the first speaker for the first scientific session, Dr. Shalu Rai. She is the principal professor and head of IDST, Department of Oral Medicine and Radiology, Modi Nagar, UP. Her specialization is in oral medicine diagnosis and radiology. She is into academics. She has 24 years of experience and research experience of 12 years. She has guided 23 dissertations, library theses, and more than 50 papers or posters in various nationality and specialty conferences. She has won a scholarship in Colgate sponsorship for research. She has published many articles in the national and international journals, has authored chapters in many books, and has authored many books as well of oral medicine and radiology. She has given several talks at national conferences, conventions, and symposiums. She has chaired many sessions at various UG and PG conferences. She is on the editorial board of Journal of Indian Academy of Oral Medicine, Radiology, and many other dental specialty journals. Now, I would like to introduce the chairperson, Dr. Prashant Penumado, who is an additional professor and head of the department in oncology, Jawaharlal Nehru of Postgraduate Education and Research, Puducherry. He is a gold medalist in surgical oncology, and he's from the Homi Baba National Institute Award he has got, and awarded by the Baba Atomic Mumbai in 2015. He has received recognition from the medical field by the poor people and has many areas of interest like robotic oncology, surgery, head and neck and thoracic oncology, peritoneal surface malignancy, and has been invited for many invited lectures. And he has done many publications and research, that is 120 publications and 60 research presentations. I would like to call upon Dr. Shalu Rai to go ahead with her presentation. Thank you, ma'am, for joining us. Ma'am, kindly put it on slideshow, ma'am. Thank you, ma'am.
Am I audible?
Yes, ma'am. Very much.
Good evening, everyone. At the outset, I would like to thank Dr. Pawan Gupta sir, Dr. Reena ma'am for giving me this opportunity. And this being a very great opportunity that I have been chosen to, talk about the oral pre-cancer and their early detection. Do it right. That's the way we are going to proceed for the detection of oral cancer cases. This is a college where I've been graduated and post-graduated from, GDC Nagpur, and the college that I have been associated with, IDST, Modi Nagar, where I am, actually teaching and gaining my experience and sharing my experience with my students. Oral health is a reflection of a physiological, social, and psychological factors that are essential to our quality of life. Oral cancer is one of the most common cause of death, and it affects the oral cavity and oropharynx, which contributes to about 3% of annually diagnosed cancer in US. Oral cancer represents more than 5% of total body cancer. And India has 33% of total burden of oral cancer globally. So we see that the majority of the oral cancer that is seen in the oral cavity are squamous cell carcinoma. And there are various sites which are there in the oral cavity, but the most common being the buccal mucosa. And when we see pan-India, there is a distribution of oral cancer as far as the age, common areas, and factors of the use of tobacco are concerned. And accordingly, there will be, the treatment dedicated to these regions. So oral cancer, why do we need, an early intervention in this? Because it's a major cause of morbidity and mortality worldwide. The oral cavity is amenable to routine screening and clinical examination for malignant changes, more easily detected and diagnosed in the early stages, leading to a more effective management. And it is considered as one of the most debilitating and disfiguring of all the malignancy. And hence the role of an oral physician plays a very important aspect, where we have to recognize this lesion at a very early stage. Because the patients are very asymptomatic at the time of diagnosis. Some patients do not seek care until pain, persistent ulceration, unexplained bleeding, or any kind of mass is detected. And they keep, the lesion then progresses into an advanced stage. So the 5-year survival following the diagnosis of oral malignancy can be as low as 15 to 50%, as most cancer are advanced and associated with lymphatic spread at the time of discovery. So the benefits of the early detection of this cancer is that it is helpful in the successful management of this lesion. It can be easily treated or removed. There are better chances of survival for the patient, and there is less stress mentally, physically, financially to the patient as well as to his family. So prevention is better than cure. An ounce of prevention is worth a pound of cure. So there are various steps, in motivating, counseling the patient. This is the primary intervention is there. You have the secondary prevention, you have the tertiary prevention. So these are the lifestyle disorder, and the changes are needed also in lifestyle. The secondary prevention is the early detection with subsequent intervention, which I'll be emphasizing on, is the screening of the patient. And then you also have the visual examination, the intraoral examination, the extra oral examination. So all these things, that is the history of the patient, the examination part, the motivating the patient and counseling of the patient plays a very crucial role. And then comes your intervention in the form of screening. . So oral cancer, as you know, is almost always preceded by a visible precancerous lesion or dysplasia. So identifying this white or red spot that shows dysplasia and removing them before they become cancer has proved to be one of the most effective methods for reducing the incidence and mortality of cancer. Early treatment prevents malignant transformation. Motivation for the lifestyle modification by reducing the risk factor usually aids in regression of these precancerous lesion. So any morphologically altered tissue in which the cancer is more likely to occur than its apparent common counterpart is the precancerous lesion. So as I can show you some of these red and white lesions that you see, these are the dangerous lesions which can be intercepted at a very early stage. And we as an oral physician, because I'm associated with an institution, I'm teaching the students also, and we get a number of cases where the patients are, ignoring these lesions, saying that he doesn't have any problem with this lesion. And then he's coming for a, other cause, the odontogenic cause. But then you should be vigilant enough to identify such lesions in the oral cavity, vigilant enough to motivate the patient to give up the habit, vigilant enough to, make them aware of such lesions and change their lifestyle. So a simple case of, even a smoker's palate, a lesion on the palate that you see, or a wrinkled area, which might be present, a tobacco pouch keratosis, a pre-leukoplakic areas. All these cases are considered now as a potentially malignant disorder, which has an increased risk of cancer. Some of the oral submucous fibrosis cases, which is very prevalent in our region. And the symptoms would be, as early as just a burning sensation in the oral cavity, vesicle formation or an ulcer, and slowly may lead to trismus. So generally the patients come in grade 3 or grade 4 cases. In that, it is very difficult to reverse the OSMF symptoms. These are how we, actually examine the cases. Examination of the buccal mucosa, the tongue, the mouth opening, and some of the findings that you are supposed to see in the in cases of potentially malignant disorders like OSMF. You see the hockey stick uvula, thickening and fibrosis of the soft palate, depapillated tongue, blanching of the buccal mucosa. Then some of the lichen planus cases, especially a case of reticular lichen planus. So they are considered as a potentially malignant disorder. And for these cases, you need an early intervention in the form of early screening. So now we come to the most important part, and that is how the cancer and the lesion that appears in the oral cavity. It could just be a non-healing sore, a lesion, a traumatic ulcer, which might be just present in the oral cavity, and the patient might not be aware of it unless and until he goes to the physician and we see the, cause, the etiology for it. It could be in the form of lump, red and white lesion, or even a numbness on the tongue, chronic pain, chronic sore throat, difficulty in moving the jaw, some form of just the teeth has been displaced. There might be a history of weight loss, voice change, difficulty in chewing, swallowing, a lump. So these are some of the early signs. So let's see about the screening, which is the, vital dye screenings or the screenings which are very important factor. So it can be divided for ease purpose as a clinical method, that is the conventional oral examination. Nothing can replace a conventional oral examination. Vital staining in the form of toluidine blue, Lugol's iodine, acetic acid, then chemoluminescence, that is Vizilite, or an autofluorescence, that is Wellscope. Then other methods are there. You have the fluorescence photography. You have various other methods, a histopathological methods, a gold standard, which is a biopsy. Different forms of biopsies are available. Exfoliator cytology, brush biopsy, And a molecular method would be in the form of tumor marker or a microsatellite markers. So what is the basis for this, the accuracy of these diagnostics test? Every test will has its own sensitivity, specificity, and a positive predictive value and a negative predictive value. We have to go through the literature, see the sensitivities, the specificity, and plan accordingly. As I told you, comprehensive oral examination is the most important thing that should be done very thoroughly, taking into the history of the patient and examining the buccal mucosa, the gingiva, the lip, the vestibule, the hard palate, soft palate, tongue, then depressing the tongue and seeing the posterior aspect of the soft palate, the posterior aspect of the tongue, the ventral surface of the tongue, the lateral border of the tongue. These are the areas which are more prone for a pre-malignant lesions. So thorough examination, knowledge of the oral manifestations of cancer may reveal finding that will aid in your diagnosis and treatment. This is the way we, examine the oral cavity. So the first oral screening method is the toluidine blue. And this is the method where we have the dye that is used. A topical application is there. You have less false positivity rate and it stains only the dysplastic tissue. Aids in diagnosis of potentially malignant lesion. It does have a specificity and a sensitivity which is higher than other, and it's higher than other stainings. Action, as I told you, it will, due to the presence of repeated phosphate group in the nucleic acid, there will be a staining property of the dysplastic lesions. And the blue stain is lost after application of 1% acetic acid solution, whereas in case of a benign lesion, but in case of a malignant lesion, you will see a diffuse areas of irregular uptake of the lesion, the dye. Some problem in changing. So in such cases, biopsy of all the site is advised, which stains positive on 2 successive visits. Because in one, if you see that there is a staining, then you go for a second after 2 weeks, and then a biopsy should be performed. But the disadvantage is that it's sensitive for identifying dysplasia is actually little poor. The color of the dye remains in the mouth for 4 to 6 hours, and it may give you a false positive report, especially in case of ulcerative and inflammatory conditions. Lugol's iodine, and this is one of the used method for precancerous lesion, and it can be used prior to biopsy and resection, and it's useful in determination of best incisional area. So it's based on binding of the iodine to glycogen granules in the cytoplasm, resulting in black-brown tissue color. Areas of dysplasia and invasive cancer do not take up iodine as they lack glycogen, and they appear mustard yellow or saffron color. So poorly stained or unstained area will be a dysplastic area, right? And a normal epithelium will stain dark brown. Whereas you can see here in a homogeneous leukoplakia with ill-defined borders and after the iodine staining. There's another method which is the utility is there of 5% acetic acid. And it reacts better with dysplastic and malignant tissue. This is also available in the literature, but it has low sensitivity, but higher specificity compared to toluidine blue. So positive finding in this, the lesion changes the color to opaque white, whereas in negative, no change of color is seen. Then the other method for the oral screening is a VisiLight, and It's a non-toxic chemoluminescent light that illuminates in the mouth. Abnormal tissues, they glow differently compared to the normal ones. And this is the method where you can see, but an instrument is required for such cases. The interpretation for this is that the suspected lesion that reflected the aceto-white light are considered visilight positive, whereas a lesion which reflected dark are considered visilight negative. You can see the figure here. Then the other method is a light-induced fluorescence spectroscopy, which is used for the early detection in oral cavity, and the sensitivity of which is 97 to 100% and specificity is 94 to 100%. The use of autofluorescence as a diagnostic tool for cancer detection was first described in as early as 1924. It's a non-invasive method, and there is this is useful for optimal location of biopsy. So in this case, a normal unaltered mucosa emits a pale green autofluorescence when viewed through a selective narrow beam filter, whereas a dysplastic tissue will show you, due to disruption in the distribution of the fluorochromes, they generally appear darker in color. So you see this beautifully diagrammed slide, which shows you a normal and an abnormal tissue, how it reacts to fluorescence pattern. So a fluorescence is red and orange in case of a normal tissue. A dysplastic will show you loss of the normal tissue fluorescence. It's painless and with no stains and rinse are required as we compare it with the Rugold's iodine or an acetic acid or toluidine blue. Thorough visual and digital soft tissue examination, useful benefit in determination of surgical border and post-surgical evaluation. It covers large surface area, so small lesions can be identified. But the disadvantage is that heat from the prolonged and close tissue examination can cause patient discomfort. There is a lack of methodological sound clinical trial in this, and a lot of research is needed. This is the histopathological examination, which we considered as a gold standard, where the specificity is really high, up to 94%. So biopsy is the process of surgical removing the tissue from the patient, and it determines the prognosis and type of treatment required, because it will give you whether it's the well differentiated or moderately differentiated or poorly differentiated lesion, and accordingly a treatment plan can be given by the oncologist. So the few of the indication for biopsy, it gives you a better diagnosis, grading of tumor is there, and evaluation of recurrence can also be done. Excisional biopsy, total excision of the small lesion can be done. You can just remove a pedunculated or a sessile lesion. You have the complete excision. A thorough excision along with the tissue is mandatory for a proper histopathological evaluation. Incisional biopsy, the other form of biopsy, if the lesion is very big, it can be performed by removing a wedge-shaped specimen of the pathological tissue along with the surrounding normal bone. Larger lesion to determine the nature of treatment. Then the other type of biopsy is the punch biopsy that we do generally in case of oral submucous fibrosis, because of the the nature of the tissue in OSMF. We have that it is more fibrotic. You have a fibrotic band. Then in that case, we go for a punch biopsy, which is available in various sizes. These are the punches, and you just need to, put it in the buccal mucosa with a certain depth so that you get the epithelium as well as the connective tissue. And then you just have to rotate and derotate, and the tissue will be there for the histopathological examination. So sensitivity is 92 to 100%. In case of even a exfoliating cytology, it gives a rapid evaluation, but then, you know, if it shows you just the epithelium changes, and if you think that there is a dysplasia there, you have to go for an incisional biopsy. So there is various, you know, definition classifications which are available, which help you to determine whether it's a, you know, on normal or a typical or suggestive of cancer or positive for cancer. So if it is intermediate, then in that case, you have to go for a biopsy, or if it is suggestive of class 4 or class 5, then in that case, you have to go for a biopsy. These are a few of the advantages and disadvantage. It's not applicable for a firm tumor, and positive, negative, false negative results are there due to inadequate sampling. FNSC is generally used for aspiration purpose. It's painless and safe procedure for rapid diagnosis, mainly for the salivary gland pathology or suspicious lymph node or a metastatic lesion. This is a procedure that is performed. Brush biopsy is also a method, but then a software is needed to analyze this, you know, the type of dysplasia that is present here. So a negative result is indicated of no epithelial abnormality. Positive result and atypical result is indicated of the abnormal epithelial changes, and in such case, you have to refer these patients for scalpel biopsy. Various molecular methods are there when we are, you know, basic thing, when we are done with it. These are the high-end quantification of nuclear DNA contents. It has its own advantage and limitations because you need a proper lab for this, because some of the chair-side investigation I have shown you, which are applicable when your patient comes, and you are able to screen those patients by help of any of these staining agents, which is known as the chair-side. Whereas in such cases, like a tumor marker or a DNA markers, this all will require a high-end lab. These are the few markers which are very specific for the particular lesions that are present. And these are the markers which can be, you know, can predict the lesion behavior. So some of the salivary gland biomarkers are there, which are, say, about 100 probable oral cancer biomarkers are there in the saliva. Then you have a lot of challenges also in such case. Fluorescence, like a direct, indirect method or a sandwich technique.
Please unmute.
Sorry, Shadi, please continue.
Positron emission tomography. This also plays an important role. And it's useful in case of an accuracy for locating the recurrent tumor or an occult metastasis. Bio nanochips are there.
Shalu ma'am, sorry for interruption. We're just running late. Can I please request if you can...
It's done. So oral cancer is growing concern with its widespread lesions, which is, you know, taking us to the top of the ladder. Unfortunately, with all the advancement in understanding of the disease process and recognition of the associated risk factor, the 5-year survival rate remains 50%. Hence, the importance of early detection, diagnosis, treatment of these lesions is to prevent their transformation to oral squamous cell carcinoma. So early oral cancer detection can happen only at the dentist level, And if such lesions are there, an oral medicine and an oral physician plays a very important role as a specialist. So an overview of the lesions and the oral precancerous screenings. So the choice has to be made. Thank you very much for giving me this opportunity.
Thank you, ma'am, for a very crisp presentation and a very good collection of photographs. It was very clear and very crisp. Thank you, ma'am. Now going ahead to the chairperson's remarks. Any remarks by the chairperson?
Yeah, Dr. Shalu, excellent talk on mandatory oral screening. And in India, still as of today, tobacco-related oral cancers are the leading causes of both pre-malignant as well as the malignant conditions. And it's very important to screen these patients because actually in the clinic, we don't see patients who come early to us. 70 to 80% of them still present locally advanced, irrespective of, in spite of all the awareness programs that are going on. So it's important that we screen them early, pick them up early, and also diagnose them early so that they either, they can be cured, cure rates can be improved. And I've got a lot of comments from Dr. Deepak on the chat box.
Sorry, Prashant, I'm really sorry to interrupt you.
Yeah,
the major fact is that no medical college has or a cancer institute has an oral medicine department. The more important thing is that we have a large study from Kerala where they looked at mouth self-examination along with people from the medical community. So if you really want to reduce the incidence of oral cancer, it has to be people who look at white lesions or red lesions in the oral cavity or ulcers. None of them are picked up by the oral medicine specialists, or because you have to understand the temporal progression of these tumors. Not all leukoplakias, not all erythroplakias change to tumor. You've got to understand the risk factors, the sites of origin, the duration of the illness, the duration of the habits, and all of that. So I think we need to incorporate more oral medicine specialists, oral maxillofacial surgeons into the oncology community. Unless we do that, we are not going to see these patients. We are never going to see these patients. And like you rightly said, everyone will come to T3, T4, and you have to do big resections and all of that. So I'm a PG of JIPMER. I did my MS in JIPMER. I know there's no oral medicine department there. I know there's no screening department there. You are forced to see patients who have highly advanced tumors. You're a very skilled surgeon. I know. I've heard what work you do, and I'm really proud. But you really can't get them at the early stage without having an integrated oral medicine department or oral maxillofacial surgeons who are doing screening. I think that is the big gap here. And all of the other things like the doctor mentioned, supravital, whatever, Visilight, Visiscope, unless you have a morphological lesion that you can biopsy, you can never diagnose oral malignancy. It is not possible at all. So I think maybe the future is to get more oral medicine specialists and dentists and oromaxillofacial surgeons involved in this. I think we are wrong. You're a surgical oncologist, I'm a head and neck oncologist. I think we are making the mistake by not involving them in the screening process. I might be wrong. Please give your suggestions. I am really immature. Your suggestions would be very important.
So Deepak, as you actually brought out a very important point, things have changed at JIPMER too. We have a very dedicated oromaxillofacial department in JIPMER, which has been there quite some time, and since even before I joined JIPMER. So a lot of screening does happen. There are a lot of rural camps that go on from JIPMER, but I completely agree, not that dedicated as what the Kerala study has shown. It's an amazing study wherein, mouth self-examination or this thing. So it is very important that integration, as you rightly said, we don't want to be seeing T3, T4 sitting in the clinic. Okay, we don't want to boast ourselves that you can remove every, half of the face and then reconstruct and do. I don't think that should be the aim. The take-home messages, catch them early. As you rightly said, there are a lot of known risk factors. Okay, yeah, screening is first thing, but we could go a little bit more, but screening is very important, and oral physicians do play a very role because this is the time where they catch them early. And a very important point rightly brought about by Dr. Deepak, that all leukoplakias doesn't need to be treated, or no, you don't need to put them, but there are very specific indications. So with this, I would like to thank the ICanCaRe.
Sorry, can I say something else? I
Yes,
think
yes,
it's
Dr. Deepak, Dr. Deepak,
substance
Dr. Deepak, sir.
issue disorders.
Deepak,
I
sir.
think it's sorry. I'm really sorry. Sorry.
Deepak sir, I'm sorry. I have to really stop you here because we are running short of time.
Yeah,
We
sure.
have very
Sure.
tight schedule on the program. We'll just take this discussion offline one more time because I'm sure there are a lot of inputs to be given, but let's stick to the schedule as of now. Thank you so much.
Oh, I'm so sorry. Thank you.
Thank you, Dr. Shalu. Yeah.
Yeah.
Thank you.
Before we move ahead, I'll just request all our faculty, we are running absolutely late. So I'll just sincerely request if you can please maintain the time, complete the session within 10 minutes. We have the chairperson remark for 2 minutes so that we ensure we have the panel discussion right on time. Thank you so much.
Going on to the next session, I would like to introduce the speaker, Dr. Shaishav Sakidas, who is a consultant at Mathuli ENT Clinic, Ahmedabad, Gujarat. He has done his MS in ENT. He works at a private practice at Ahmedabad since 2012. He's in charge of the ENT department at Ahmedabad and is a consultant in various areas. He has done co-ablation guided surgeries, laser guided surgeries, so on and so forth. So, esteemed speaker, and the chairperson is Dr. Nair, Deepa Nair, who is a professor and associate surgeon at the Tata Memorial Center. Areas of interest are skull-based malignancies, HPV negative oropharyngeal cancers, and minimally invasive head and neck surgery. Both our speaker and chairpersons have many publications and chaptered and authored many chapters in many various books. Now, going on to the speaker, please shed some light on the topic of pan-endoscopy. Thank you for coming, sir. Dr. Shaishav Sakidas, all to you.
Thank you, Durga ma'am. Thank you. Good evening, everyone.
Good evening, sir.
Thank you, organizing committee, to give my thoughts on the topic, which is of our areas. Pan endoscopy, a way forward. Am I?
Your screen is not visible yet. We'll request if you can share the presentation.
Just hold on. Yeah, is it visible now?
Yes, visible, sir. Thank you.
Pan endoscopy, a way forward. Basically, pan endoscopy word has been coined in the era where we don't have much imaging and probably a PET CT and everything available. Basically, it consists of nasal endoscopy or nasopharyngoscopy, laryngoscopy, bronchoscopy, and esophagoscopy. Now, in the context of oral cancer and cancer for the aerodigestive tract, what are the indications where we should consider pan endoscopy? The basic indications are to diagnose the lesion, inspect the lesion, evaluate the lesion in the basically the site of the lesion, the size of the lesion. At times we palpate the lesion for this consistency, and the main aim is to take a biopsy and to prove the biopsy to prove histopathologically the type of the tumor. Now, the second indication, having done this thing, is to plan our surgery whenever surgery is possible. The extent of the surgery needs to be planned on the basis of that. And when their surgery is not possible or the surgery needs some other modalities, it is to be considered on the basis of endoscopy. The other indication could be the look for the primary in case of unknown primary, where pan endoscopy, which consists of esophagoscopy and bronchoscopy, has a major role to play. It is also to be considered to rule out or diagnose second primary or a metachronous primary. It is also important to supervise the patient while neoadjuvant therapies and also during the surveillance time. Now, the first and foremost important thing is a laryngoscopy. Usually in ENT practice, as patient represent to us, we usually do nasal endoscopy in almost all patients. So nose and nasopharynx usually being seen by us. Second come when there is a oral lesion or any aerodigestive lesion is a laryngoscopy. Whether you consider rigid scopy, whether you consider flexible scopy, whether you do it Hopkins, but it has to be done in all patients where is a suspected oral lesion or there is a diagnosed case of oral lesion or oral carcinoma, or in the cases of neck swelling or lung. The area of concern in laryngoscopy is oropharynx, hypopharynx, and larynx. The advantages of flexible scope is very distinct office-based procedure, no anesthesia, and you can see the vocal cord movement, which is not possible when you are doing direct laryngoscopy under general anesthesia. Now we are considering pan endoscopy. What are the advantages over of the flexible scopies or rigid scopies? When we consider flexible scopies, it is always done under local anesthesia or in minimal sedation. It is a very less mortality. It is an office procedure, so patient workload can be reduced in a hospital. It can be done with a restricted mouth opening when we insert scope from the nose, and it is far superior vision than the rigid scope. What are the advantages of a rigid endoscopy? There are few indications where rigid endoscopy can be considered over flexible scope. That is when you are watching or you are examining hypopharynx or at times postcricoid region. But still, with experience and flexible scopes does wonders. Now, when coming to the bronchoscopy, nowadays where we have a PET CT, MRI, contrast with CT, there is a very limited role in all patients in absence of radiological chest findings, but it has a very distinct role in case of occult primary where you don't know where the primary is lying. So that should be considered, and it will also help to take biopsies and to take cytological specimens. Now, when we are considering esophagoscopy as a pan endoscopy in cases of oral or aerodigestive tract malignancies, there are certain distinct indications where we should consider this. I think in all cases where the primary is suspected either in a postcricoid region or in esophagus, it is to be considered. It is to see the lesion, type of the lesion. We can examine and take a biopsy from the particular site. All hypopharyngeal malignancies diagnosed or suspected usually should be followed by esophagoscopy to see the extent of the lesion. Young patient where the primary is oral cavity or in oropharyngeal region or in aerodigestive tract, you should consider as young patient is a high risk patient for the second primary or synchronous primary. So it is to be considered. This is what we advised. Whenever the patient has a history of alcohol, smoking, tobacco, chewing, that are all very high risk factor for synchronous and metachronous primary, where esophagoscopy as a pan endoscopy is, I believe, indicated. And it is a very distinct role in cases of unknown primary, where patient is represented with the secondaries into neck, and even PET CT or CT scan MRI is negative. Esophagoscopy has a very distinct advantages. Now, pan endoscopy in cases of occult primary. As we know, the occult primary usually represents 3 to 5% of probably all head and neck malignancies. Even PET CT in now era can diagnose only up to 40% or around that area. It cannot diagnose the all occult primary cases where the primary occult cases where the primary is high. So I think pan endoscopy has a very distinct role in cases of occult primary. Pan endoscopy can diagnose. Esophagoscopy can particularly diagnose cases where even PET-CT is negative, and it actually yields more results in biopsy-proven diagnosis. There are n numbers of articles, publications are there where they have done prospective studies where they have done endoscopies, CT scan, and PET-CT as a prospective study. And there are very distinct studies which suggest that there are high rate of diagnosis of cancer in PET negative patient if you follow pan endoscopy as your protocol. And there are also other articles where you are following everything and still PET-CT cannot diagnose a good number of occult primary cases where you add endoscopy as a conjecture with the PET-CT, your diagnosis can increase up to the 45% cases. Same again when we are dealing with the oral cancer or oropharyngeal cancer, there are different.
Kindly, all the other participants be on mute and don't disturb the speaker.
Sorry. So when we are talking about synchronous or metachronous primary in cases of oral cancer or orodigestive cancer, there are again different publications where the percentage of synchronous or metachronous primary in general varies right from 2% up to the 19-20% on various publications. Where there were no CT scan, MRI, or PET-CT were available, probably wherever pan endoscopy done as a prospective studies or prospective protocol, the diagnosis of synchronous or metachronous primary usually had a higher incidences, and endoscopy has a major role. So I believe nowadays when we have a PET-CT or a CT scan or MRI available, probably wherever we have a occult primary or multiple primary or suspecting multi-primary in a high cases, we should do a CT scan or MRI and or even PET-CT if financial constraints are not there. And in high risk cases, we should consider bronchoscopy or esophagoscopy to rule out second primary or a metachronous lesion. Narrowband imaging. It is a new dimension in the field of endoscopy. It helps visualize the suspected area better. It helps in selecting site for biopsy. It differentiates benign lesion from the malignant lesion on the basis of the vasculature we can observe in a blue light and green light, along with white light, which we are routinely use. It guides us to the type of the lesion on the basis of vasculature. As I said, when there is a homogeneous vasculature, maybe your lesion is a benign lesion. When there is an interrupted vasculature, it could be a malignancy. On the type of the vasculature, you may label it either it as squamous cell carcinoma or adenocarcinoma, and that will guide us to further. The most important advantage, it can be used even in a rigid endoscope and also be in a flexible endoscope. So it is a very important tool when we consider endoscopy in a diagnostic and staging procedures for our patient. To conclude, I believe laryngoscopy is mandatory in all cases of oral cancer and orodigestive cancer. Flexible scope has a very distinct advantages over rigid scope. Narrowband imaging has an important tool in nowadays to evaluate the lesion. In case of unknown primary, we recommend that pan endoscopy should be included in the protocol. Preferably, it should be done whenever we are considering PET-CT. It should be done after PET-CT. Esophagoscopy should be included in high-risk cases in all hypopharyngeal malignancy to rule out second primary or metachronous primary. Diagnostic yield of esophagoscopy is very significant even in PET negative cases. So it should be considered. The role of bronchoscopy has decreased in the era of imaging, but it should be considered whenever it is indicated high risk patient or where primary tumor suspected in case of occult primary in a tracheal or in aerodigestive, in a respiratory tract. So to conclude, pan endoscopy should be a part of our protocol, but rather than following all endoscopies as a it has been coined in a past era, we should consider bronchoscopy, esophagoscopy on a case-to-case basis, on the basis of high risk and the patient's condition. Thank you. Patient survival is our satisfaction.
Thank you, Dr. Sakhidas. I think you summed it up very well. Pan endoscopy, which conventionally was described, I think when I was training or even before that, was suggested rigid endoscopes, rigid endoscopic evaluation under general anesthesia of all these areas. Since our topic for today is basically oral cancer, the role of pan endoscopy for diagnosing a known oral cancer is limited. Like you rightly said, you're looking for a second synchronous primary there. And most of the times we would do flexible scopies just to evaluate the oropharynx, the laryngohypopharynx in these cases. The role of pan endoscopy is as an upfront diagnostic modality reduces with the incidence of better PET CT scans and better imaging, especially for unknown primaries, like you rightly put it. And it is complementary with your PET CT scans. It helps you additionally, like you very rightly said, it gives an additional yield over the PET CT scan to diagnose mucosal lesions, which may not be picked up on a PET CT scan when it's talked about in an unknown primary case. And just a couple of points that now you can also do something called a transnasal endoscopy, which is a shorter flexible fiber optic esophagoscope. Compared to the 110 centimeters, you have a shorter scope, which is around 70 centimeters, which has insufflation modalities. So you really can do evaluation in the OPD itself by insufflation of the hypopharynx, postcricoid, and the upper esophagus. So you don't really need to do take the patient to a big endoscopy suite and give the patient sedation or anything of that if you want to do esophagoscopy. I think there are some questions about how will you identify submucosal lesions on pan endoscopy and how will you target a biopsy in these cases. So I think if the lesion is completely submucosal, unless you are very vigilant about it, and you have to correlate with your pre-imaging, your imaging before the scopy. So you will look at those sites and most of the times you'll see a subtle bulge. If you're doing an endoscopy and it's completely submucosal, it's unlikely you're going to be able to biopsy it adequately through a fiber optic endoscope because the biopsy channels are very small and the tissue bits which you get will be very small. In such cases, either you can think about a image-guided biopsy, or maybe then you would have to consider taking up the patient for the anesthesia and then doing an incision of the mucosa and then targeting a biopsy. So that's my take on it. And do you have any other things to add, Dr. Sakhidas?
I think you're rightly said. Mostly when you are suspecting or you are having a submucosal lesion, whenever you're doing endoscopy, probably, and if you have done good number of endoscopy, probably you will pick up the suspected areas. If you can take a biopsy either with flexible scope or rigid scope, whatever, probably you will have a submucosal lesion, you will get it. But if your lesion is not accessible by the scope even, then you have to rely on the PET CT to really confirm if it is possible, and either you can do an image guided biopsy, because otherwise we probably not have other options to be doing it. So I'll go with you. Thank you, ma'am.
Thank you, Dr. Shaisha, for a very crisp and perfect presentation, and Dr. Deepa Nair for your comments on the expertise. So thank you, ma'am, and thank you, sir. Now going on to the next session, I would like to introduce Dr. N. Aravinda Babu. He's a professor and HOD of oral and maxillofacial pathology in Balaji College of Dental Sciences and Hospital in Chennai. He is an expert in oral cancer prevention research, and he's a vice president of the Indian Association of Oral Maxillofacial Pathologists, associate editor, and his highlight is first of its kind in the world to come out with dental awareness book in Braille, sign language CD for hearing impaired. He's a director of Arvind Multi-Specialty Dental Cancer Center, Adabakam, Chennai. Coming to the chairperson, he is Dr. Deepak Balasubramaniam. He is a professor at Department of Head and Neck Surgery and Oncology, Amrita Hospitals. He has participated in various head and neck reconstructive surgeries. He has a passion for both cancer, reconstructive surgeries alike. And he has attended many national and international meetings involving head and neck ablative reconstructive surgeries. He is actively involved in training of many residents in Amrita College. And going on to the topic, salivary biomarkers and biosensors for early diagnosis, I would call Dr. N. Arvinda Babu to throw light over the topic. Thank you, Doctor, for coming.
Thank you for the introduction, madam. Good evening, all. Madam, can you disable?
Yes, sir. You're audible, sir.
No, I want screen sharing option to be.
I can hear you. Please carry on.
Durga, you need to stop share screen.
Yes,
Allow
sir.
Dr. Arvind.
Okay, sir. Okay.
Allow me to screen share, madam.
Yeah. Fine, sir.
1 second, madam.
Yes, sir. Sure.
Is it visible, madam?
Is it? Not
Yes,
yet.
So open the presentation and then the screen.
Yes,
share, sir.
yes, madam.
Yes, sir.
Few seconds, madam.
Sure, sir.
So would you like to drop me the presentation quickly? I'll share it on your behalf.
Madam, I'll just put it in the group, madam.
Yeah.
I'll post it, madam.
I'm sharing it on your behalf, sir. Can you see the screen?
Yeah. It's not visible.
Yeah, please go ahead. Please instruct me to change the slide and I'll keep changing the slide.
Yes, madam. Yes, madam.
Yeah, thank you.
Also to save time, you can start giving your.
Yes. Let me start. Let me start. Let me start, madam.
Introductory.
No, let me start. Good evening, one and all. Sorry for the inconvenience. I thank the organizing team for giving me the opportunity to giving me the topic of biomarkers and biosensors. As our Director of Education from Gujarat University, sir, exactly said that we have to do mass screening and we have to find something accurate way of diagnosis. I think two of my previous speakers, they spoke everything about the lesion, how it manifests in oral and maxillofacial region or oral cavity, or and my another speaker spoke how the lesions appears to be in larynx, nasopharynx, or pharynx. Now this is an backslide, madam, backslide. Now this is a great opportunity for me. We are in such a state. There are so many articles. What it says means we can able to detect the cancer before it clinically manifests. So now in the previous two presentation, we were discussing about the clinical manifestation of the cancers, whether it may be in the form of ulcer or ulceroproliferative lesions or in the form of red color spots or white spots or whatever it may be. What I am going to talk is some biochemical changes which occurs nearly 2.5 to 3 years before it clinically manifests. So this is the right place where I am going to cut, or we maxillofacial pathologists are targeting to catch the audience in a cost-effective way. Both things. I can't detect something and which will be not able to afford by a common people. So we have two things. As the epidemiology, as previous speaker, oral medicine chief madam told, everything men is common than female, and everything. It's at the age of 2026. I expect 1 lakh and above cases to be reported from male and 55,000 cases reported from female. Next slide. Okay, now I'm going to think about biomarkers. Biomarkers may be from any body fluids. It may be a serum biomarkers or it may be a saliva biomarkers. I'm going to concentrate on non-invasive and cost-effective biomarkers. Why I take saliva means saliva is a mirror of body. Okay, it's safest, very less technically experienced people can do. In mass screening, no, we can't expect technically expert people to go and collect blood or go and collect some other samples, DNA, RNA samples. But saliva collection, probably we can include our postgraduate students, we can include undergraduate students, and the collection is very minimal invasive, and it is not coagulated and cost-effective biofluid. It is readily available in adequate and large volumes. We can get whatever the amount of volume, 2 ml or 5 ml, we can able to collect. Next slide, madam. Okay. The whole saliva is a unique and complex. Both it is in sources and composition. Actually, we don't get pure saliva form. We get saliva exactly from salivary gland, or whatever saliva we get from oral cavity, it will be with GCF or with mucosal transudate, or with secretion from nasal or pharyngeal mucosa, or non-adherent bacteria, or discriminative oral epithelial cells, or keratin debris, blood cells, food or medication residuals. Next. I just want to give a brief definitions what is biomarker and what is tumor marker. As per the United Nations, WHO says a biomarker is any substance, structure, or process that can be measured in the body or its products. Product means body's products, and influence or predicts the incidence of outcome of a disease. It's going to predict the outcome of a disease. Okay. Tumor marker can also be defined as a specific, novel, or structurally altered cellular macromolecules, or temporary or spatially or quantitatively altered normal molecules. These are the altered molecules which is in the circulating fluid, either in the blood or in the saliva, which can be seen in a benign or malignant neoplastic cells. Next, madam. Tumor markers. Tumor markers are substances that are produced either by the tumor itself, either by the tumor, or the response from the body to the tumor. So two things will happen. First, tumor will exhibit some sort of markers, or the response of the body will give some sort of markers. I have to detect either one. I have to catch either one of these markers. If I catch one, if I catch the body's response, I can say the prognosis of the disease. If I catch the tumor response, I can say that prognosis. Again, what is the prognosis of the tumor? What is the prognosis from the body it gives? it's a diagnosis of cancer, it's assessment of tumor burden. Tumor markers have been used to predict the recurrence of a particular disease. Few markers are specific for a single individual tumor. Most are found with different tumors of the same tissue types. Next. What are the applications of biomarkers for oral cancer? Biomarkers help in evaluating the preventive measures or therapies and the detection of the earliest stage of oral mucosal malignant transformation. It reveals the genetic and molecular changes related to the early, intermediate, and late endpoints in the process of oral carcinogenesis. It is refined the ability to enhance the prognosis, diagnosis, and treatment of oral carcinomas. It helps in monitoring progression, recurrence, and treatment compliances. It's useful in early stage of cancer during development itself. Determine efficacy and safety of cryopreventing. Okay, ideal characteristic of tumor marker should be of these structures. It should be highly specific. It should be highly sensitive. It should be long lead time. The levels correlate with tumor burden, short half-life, simple and cheap test, easily obtainable specimens. Next we'll go. Next slide. Okay, fine. So here, from here onwards, what I'm going to speak, these are the techniques what we use to find the tumor markers. Now the trend has been changed. We have three main role as a biomarkers. One, the biomarkers used for precision medicine and for targeted therapy. So what information I'm getting from the biological fluid, it is going to help me in diagnosis of the lesion or to tag whether the patient is sensitive for chemotherapy or the patient is sensitive for radiotherapy or the patient is has to go for surgery, or it can be used for a prognostic markers. Basically, DNA, mRNA can be used. It can be used in the form of next generation sequencing, microarrays, PCR, quantitative PCR. Next, madam. Next. Okay. Then study of proteins. The two-dimensional gel electrophoresis can be used, and reverse phase liquid chromatography should be used, and matrix-assisted laser depolarization can be used, and it can be followed by malady of MS, high-performance liquid chromatography, radioimmunoassay, or ELISA. These are the methods where we can study the biomarkers. Next, madam. These biomarkers, we have group of combinations. Whether I have to detect the cell cycle progression, or I have to detect the tumor suppression and apoptosis, or I have to detect the hypoxia conditions, or I have to detect the angiogenesis, or I have to detect the cell adhesions and matrix degeneration. Because the tumor cells are polyclonal. Polyclonal in the sense, each and every cell has its own role. Some part of the cells will start synthesizing its own food. Some cells will planning how I have to go and metastasize. Some cells will plan how I have to start a budding new capillaries. Some cells will decide how I have to go for mutations. So there is a polyclonal cells I can't be able to target. I think this is the one of the reason where I can't come to a targeted medicine or specific chemotherapy in oral head and neck cancer region. Whereas in breast cancer or cervical cancer, we got so much of chemotherapeutic agents. But in oral cancer, we have less amount of chemotherapeutic agents because it's a multifactorial things which is happening by each and every clonal of cells. Next slide, madam. Okay, these are the things. I don't want to detail much. Probably it may be easy for myself. For some other field of people, it will be much more difficult to understand what are these things. This EGRF is a epidermoid growth factor. When I see overexpression of EGRF in a biomarker, I say the poor prognosis. For example, tumor suppressor, if a P53 expression overexpression, I will say poor prognosis. Okay, then hypoxia. If I see HIF1 alpha, then diffuse overexpressions, it is good prognosis or controversial. Next. Then angiogenesis, vascular endothelial growth factor, if it is positive marker, then it's poor prognosis. CD105 high expressions, the recurrence will be more. So cell adhesion molecule, MMP, matrix metalloproteinase, and CD44, E-Cadherin, whatever it is positive or negative, that will results in poor prognosis or poor overall survival rate. Then humoral biomarker, the parathyroid hormone related protein marker, endothelins and the receptors, inflammatory cytokines. These markers will help me whether the tumor can be converted into malignant conversion or the tumor growth and progressions, all the tolerance of our immune system. So everything for immune-related marker I have inflammatory markers, I have angiogenesis marker, I have epidermal growth factor marker. Each and every components, I am coming out with some set of markers. Next slide, madam. Next slide. Basically, salivary biomarkers can be derived from DNA sample, RNA sample, mRNA, protein, peptides, long non-coding RNAs, non-organic components, oxidative stress-related molecules, glycosylated molecules, glucocorticoids, and metabolomics. These metabolomics, omics in oral cancer, it is the topic which is going on. Omics and precision medicine. The DNA, potentially salivary markers can be DNA markers, protein markers, and RNA markers. These three, I am going to call it as a potential potential oral SCC markers. Next, madam. Next. Okay, these are some markers they are given in their article. The DNA markers, C deletion in exon 4, promoter methylations, and P16, NGMT. These are the P16. These are the proved markers what we already have. Now, the only thing is we have to prepare a panel of markers. I have so many lots and lots of markers in my hand. I don't know for whom, what marker I have to do. Which lesion, what marker I have to do. Next slide. Next, madam. These are the RNA markers. Again, RNA markers. The RNA transcriptome, we have interleukin 8, SAT, S100 protein, MIR, and DUSUPA, and it has a different for interleukin 8, which has a play. It's a player in the tumor angiogenesis. Like that, everything has a role in their tumor progressions. Next. Protein markers. These are the protein markers. Interleukin 1 beta, vascular endothelial growth factor, matrix metalloproteinase, mammary serine protease, cyclin, total sialic acid, actin, myosin. These are the proteins which I am going to detect from protein markers. Next. Protein biomarkers and its outcomes. Next. Why panel of biomarkers for OSCC in Indian populations? Why? We don't have. Well, the reason is OSCC due to different tobacco habit. We don't have a similar habit across India. I think first presenter had showed a map where the percentage of cancer varies in north, east, west, and south. Why, if tobacco, if it's a common, why the same India or a same Indian statistic, different percentage of commercial cancer occurring in South India, then North India, then East India, and West India. We have different ethnicity and we have different tobacco itself in different form of nicotine composition and tobacco composition and refined form of preparation and raw form of preparation. So many things are there. It's not like in European population. We don't have a proper traded or branded things. We use more of unbranded things, and we use more of self-prepared tobaccos and self-prepared nicotine components and all these things. Next. In globally, Brazil, China, Croatia, Hungary, they have a panel of markers. They have examined these panel of markers. In India, LDH, MUC16 and interleukin 18, these have been added in list, and still we have to come in a proper list of markers in Indian populations, so that it will be easy for me to write a prescription, go for these markers, and then I can say whether the patient smoking for 10 years will develop oral cancer or not, whether the patient having a tobacco-related habits will develop a cancer or not. So there is so much of questions. Patient with tobacco chewing habits with 10 years will have a very poor prognosis cancer. Patient with 30 years of smoking, which have very good prognosis of cancer. And
so you are saying that you will take 10 years people with tobacco habits and you do some markers, and these people are high risk of tumors.
Yes.
What evidence do you have?
I'll just let me finish it, sir. Let me finish it, then we'll have the discussion, sir. Let me finish it.
And you also said that if you have vascular growth markers epidermal growth markers, they're all pro-prognosis. What is the clinical evidence you have? You can run thousands of markers, but what is the translational effort that you have?
So, Dr. Deepak, please let Dr. Arvind Babu finish his presentation. After that, you can go ahead with the chairperson's comments. Thank you, sir.
Thank you, sir. Let me finish and get back to all the questions, sir. And it will be interesting for me to answer these questions and all. Then this is the schematic diagram. circulating mRNAs and therapeutic targets or prognostic markers. The circulating mRNAs, what we are getting, it's a therapeutic targets. It can be used as therapeutic targets. Whether with this marker, I can say the lesion is radiosensitivity or the lesion is chemosensitivity. Then with the prognostic marker, I can say the prognosis of the disease and I can say the metastasis of the disease. Probably these can help the surgeons or help the treatment providers to think what adjuvant therapy they can do or what combination therapy they can do. It's a single mode chemotherapy or chemoradiations or chemoradiation or surgery. This can be, I can able to provide some information for the treatment of the patient or benefit of the patient. Next. Present salivary diagnostic aids in oral squamous cell carcinoma. Apart from biomarker, there are certain things called as biosensor. Again, this biosensor can be determined from DNA, RNA, and proteins. Next slide, madam. Next, very fast we'll go. The DNA biosensor is nothing but the DNA is hybridized with a fluorescence and labeled probe with methylene blue probe fixed in gold electrode current detection. Next. This is an instrument. Next, previous. This is an OFNASET is an instrument where it's a salivary proteomic and mRNA biosensor, where this instrument can certain level will pick up the data what we have already feed inside, and this will help in to examine the examine the two salivary proteomic markers, sensory contains and capture the detector probes. To capture probes anchors the target of the sensor. So whatever we can able to do, that sensors can be read by these markers. Next, these machines. Next. So these are the some site of interleukin and RNA biosensor. Next. Then with the help of light, like Raman spectrometry, from this light method, we have light emissions. We can able to diagnose some sort of markers. Next. Then mRNA biosensors. This is based on magnetic beads. This is a probe and a magnetic beads based biosensors. Enzymatic catalysis amplifications makes the biosensor ultra high sensitive and discriminationally ability to even for the detection of similar mRNAs. It can be used to detect very low oral cancer related mRNA. Even the specimen is very low also. With this mRNA biosensor, I can able to detect the sensor and I can be able to give what exactly the tumor biochemically says. The language of biochemical is much more different than clinical language and other language what the lesion talks. I basically see the cellular language. I am basically a pathologist. I sit with the cells. I see the cells and I see how the cells speak to me or how the cells resembles to me with a normal nuclear pleomorphism or hyperchromatism or whatever things what I see, whether the lesion is metabolically.
So I request you to please make it a little short, sir.
No, next, I'm finishing. Last slide. Last slide. Next. It's last slide. Next. So this is another interleukin protein microfluid immunoarray. Next. This is another type of biosensors. Next. So these are the biomarkers, samples, and what methods we can use, what detection limits, the level of biomarkers in normal and cancer prevention. Next. Same thing. Next. So in future prospectus are to create prognostic markers for oral squamous cell carcinoma from India, identification of specific panel of biomarkers for the diagnosis, prognosis, chemosensitivity, and radiosensitivity. The next point is to develop cost-effective point-of-care testing devices for non-invasive rapid diagnosis and prognostications. Next. It will be a conclusion slide. A large number of molecular markers are associated with occurrence, progressions, and prognosis of SCC. There is an ever-growing number of molecular markers. We have lots and hundreds of markers. Then we have to sit and standardize which are the primary markers, which are the secondary markers. And it should be emphasized that tumor markers should not be the primary modalities for the diagnosis of oral cancer. Their main utility in clinical medicine should be laboratory test to support the diagnosis. Next will be a last slide. Next. So in future, it will be a sort of rapid kit, like a sort of pregnancy kit. A drop of saliva is kept over the change of color, which will indicate some sort of positive result to you. So it's a sort of immediate diagnostic marker instead of what what I have to do it in a sophisticated lab with RT-PCR next-gen sequencing. We are in a mode to come with a on-spot diagnostic thing. So it's better we have to update ourselves in salivary markers and salivary biomarkers, and it can be taken to the common public, and it can be educated to the medical fraternity to get the utmost benefit from the biomarkers. Thanks for the opportunity. I'm ready for the questions.
Thank you, sir, for this brilliant presentation. Now coming to the chairperson's remarks, Dr. Deepak.
No, you are so overwhelming on saying that you can decide what biomarker is good for radiotherapy and what biomarker is good for chemotherapy.
Yes, sir.
What is your clinical evidence? I've been in this field for more than 20 years.
Sir,
and I'm well aware of what evidence you have to prove or what evidence you have to see. And then you said that you have evidence that certain angiogenesis markers and certain EGFR markers. Where is your translational research? You're doing on all cell samples. Where is the translation into clinical samples? Do you have any evidence or publications?
Yes, sir. Yes, sir. I've quoted all the authors' name before my biomarkers. It was in my slide. Every articles what I am told, and I myself have published an article. You can I can send the link of my articles. I am doing research.
So, what was your result from your articles? You saw improved survival in radiotherapy with your specific markers. You saw improved survival with your chemotherapy markers. What was your cutoff?
Yes, sir. I have a oral cancer lab. I am in tie-up with Adayar Cancer Institute, Chennai, IIT Chennai, IBMS Bangalore, and we three are doing a very massive study. I have screened population of 26,000 population screened and 26,000 salivary samples, and we are doing we have got a grant from ICMR around 36 to 37 lakh. Like 2009 itself, Barack Obama had said in United Nations that the precise medicine and the translation medicine, it is going to be the treatment of choice.
But I'm very sorry, I have never read any of your publications. None of them have been published.
No, sir. I see. You know, this is the first time we both are speaking. You don't know whom I am. So you just
no. I really appreciate your presentation. It's really good. It's really eye-opening. I just don't know. It's my ignorance. It's not anything to do with you.
No. I'll personally.
It was an excellent presentation. Excellent presentation. Thank you, Dr. Arvind Babu.
Yes, madam.
Now shall we go to the next session?
I just want one question for a minute. So you're saying that you can target people who will benefit from radiation therapy.
Angelina Jolie, I think everybody knows in newspaper, she had got a precise medicine in breast.
No, I don't care about Angelina Jolie or husband. I'm just asking you a question.
Short of time,
are you able to say that you have a certain specific set of patients who will benefit from RT? That's all I know. Because I can offer my patients the same thing. That's all. I'm just ignorant about it.
Of course, sir. Of course, we are on the way. And surely it has to come to the table, and not from lab side. It has to come to the chat side. So we are bringing it to chat side.
And why did you say that patients who are angiogenic inhibitor positives don't do well? And you said EGFR also doesn't do well. What was the reason for that?
Vascular endothelial growth factor, it creates neoangiogenesis, sir. It feeds more, sir. So
no, but we have VEGFR inhibitors which have worked. So how did you say that you didn't do that well compared to? Sorry.
No, one second. Just listen me, sir. You just listen me. That is working in breast cancer. That is working in other cancer.
I'm talking about head and neck cancer. I know in breast and all the other cancers, but I am asking you a question. You said EGFR and VEGFR were bad. How is that bad? Because that's what most of our treatment is based on now.
It's based. I'm accepting what you say, sir. But if any alteration in EGFR, there are chances of getting malignancy. We can able to control that. If any lesion with showing more amount of vascular endothelial growth factor, I can say the lesions having more tendency to have a metastasis. It will synthesize its own blood vessels. And
so you're saying VEGFR inhibitors have more metastasis. That's your logic.
No, not in inhibitors. Inhibitors is the things which is inhibiting the VEGF. Okay, I am saying that when I see more amount of...
So, Dr. Deepak, Can we have
Yeah,
this
we will stop here.
discussion a little
You
later?
did a
Because
very
we are
good
running
talk.
short of time, Dr.
You did a
Deepak.
very good talk. I'm really sorry. A very good talk. Very, 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 very good talk. And
Yes, thank
so
you,
much
Dr. Arvind
information.
Babu.
Thank you
Thank
so
you,
much.
Dr. Deepak.
Thank you so much. Thank you so much.
Yes, thank you, sir. So going to the next topic, malignant potential of oral lichen planus. I would like to introduce Dr. Vasanti Jirge, who's a professor of oral medicine, radiology, KLE Dental College, Bangalore, Belgaum. She is a consultant and reader in the same college, and she has co-authored several books, and she is an internationally certified life coach. Her niche areas are academicians and success coaching for women. Now, I would like to introduce the chairperson and would like to thank Dr. Rajendra Gowda Patil to accept our invitation at a very short notice. And special mention that he was my sir and my teacher in my UG and PG days in SDM College, Dharwad. He has completed his UG and PG from Belgaum, has 25 years of teaching experience, has delivered more than 40 guest lectures in CDA state and national conferences across the country, selected as key resource persons, and has 16 national and 20 international publications. I would like to call upon Dr. Vasanti Jirge to speak on the topic of malignant potential of oral lichen planus.
Thank you so much.
Dice
Dr.
given to
Durga.
you. Thank you.
Thank you, Durga.
Thank you.
Thank
Can
you,
I
sir.
share my screen now?
Yes, sir. Yes, ma'am.
Can you see my screen?
Yes, ma'am.
Okay, so good evening, everyone. At the outset, I would like to thank the organizers, Dr. Reena Gupta, Dr. Reena Kumar, Dr. Pawan Gupta, and Dr. Shruti for having me, for honoring me with inviting me here to be with you all once again. And today's topic is very focused. It's malignant potential of oral lichen planus. And so the objectives of my presentation are that by the end of this session, the viewer should be able to appreciate the importance of early diagnosis, management, and follow-up of oral lichen planus. Now, I'll be covering this session under three main headings: what, why, and how. So oral lichen planus is a chronic immune-mediated inflammatory disease of the oral mucosa. And it has been widely studied and researched. And after a lot of researching and a lot of people coming together, most recent literature states that the different kinds of oral lichen planus kind of lesions be brought together, and it's now called a group of lesions, oral lichen planus. There's oral lichenoid contact reactions, oral lichenoid drug eruptions, and oral lichenoid reactions of graft versus host disease. Now, why these have been brought together is that although they have different precipitating factors and seemingly different presentations, there's a lot of similarity in the way they appear and present. And also when histopath or biopsy is performed, the microscopic structures, the microscopic pattern is also very much similar. So it's hard to distinguish between the different types of lesions. It has also been found that this is a delayed hypersensitivity reaction. So all in all, what we can say is a chronic immune-mediated delayed hypersensitivity type of inflammatory disease of the oral mucosa. Why is it important that we understand how oral lichen planus works is because it's a chronic disease, it's incurable. There are multiple triggering factors, and some of them being inherent and some of them could be some external factors also. So most commonly found in females and most commonly associated with stress, the precipitation is seen when there is periods of stress. It's a widely researched enigma. Until now, researchers haven't found one particular antigen that can trigger an attack. So that's where the enigma comes from. And also, what are the reasons it is aggravated? And although we have different treatments that can provide remission from the disease, the aggravating factors are still, the different people present with different periods of disease-free intervals. So that's why it's an enigma. And the prevalence globally is 0.5 to 2%, whereas in India it is 0.2 to 3.8%.
and it is a potentially malignant disorder. Now, previously, we are familiar with the term pre-malignant lesion or condition. So I would like to refrain from using the word pre-malignant because it denotes a stage prior to development of malignancy, and not every lichen planus case is going to turn into a malignancy, which is why we should avoid using the word pre-malignant and we should stick to the term potentially malignant disorder. So oral lichen planus is known to be a potentially malignant disorder. The next important point is the malignant transformation rate. Now, in literature, it is found that the malignant transformation rate varies from population to population and also within the country. So it is found to be 0.44% to 2.28%. Now, why this is controversial is because the study designs are not homogeneous. There is a wide variation in methodology in the way these rates have been studied or documented. So they are either hospital-based studies or community-based studies. And so you cannot extrapolate hospital-based study statistics to the community. The next important point is the follow-up rates. So different populations have been followed up for different periods of time. Now, once a person has been diagnosed with oral lichen planus, he or she can develop cancer at any stage in life. So the one who is predisposed to developing it. So therefore, since across all the studies, we find that there's so much variation in the way this has been documented. So this statistic is a bit controversial according to literature. So now there are different clinical presentations of oral lichen planus. I will not go into the details of that because it will throw us off the focus of this topic. So we have reticular patterns, we have erosive patterns or the erythematous, and there's hypertrophic. Now, if you look at the picture shown here, the picture above is a reticular pattern and the one at the bottom has more of red areas also. So that has erosive or atrophic component. The next is the lesions on the tongue. So if you look at the lesions on the top, on the lateral border of the tongue, it's more of a reticular pattern, whereas the one at the bottom is also associated with an erosive component. So how do we identify risk of malignant transformation is first of all by identifying what clinical variant it is in any patient. Reticular patterns have a lesser tendency to turn into a malignancy. And reticular patterns also tend to be asymptomatic in many patients. So the ones that are symptomatic are the erosive or the atrophic ones. And these are the kinds that have a greater likelihood of transforming into a malignancy. Next feature for risk of malignant transformation is the location. So it has been found that lateral lesions on the lateral borders of the tongue are more likely to turn malignant. This is among the patients who have a higher chance of developing a malignancy in the lichen planus. Then patients who are undergoing immunosuppressive therapies might be at a lesser risk of malignant transformation. Then histopath, if dysplastic changes are found on histopath, then these patients have to be followed up for a long time. And if it's a smaller lesion, then excision biopsy would be good. But if it's a larger lesion, then they have to be followed up with the appropriate management protocols. Last and the most important risk for transformation is a patient who is concurrently using tobacco and or alcohol. Now it is very well understood and known that tobacco and alcohol cause oral cancer. So if a patient has an erosive or atrophic lesion, let's say on the lateral border of the tongue, and also uses tobacco and or alcohol, then this patient may be at a higher risk of malignant transformation. And that does not mean a patient with a reticular lesion will not develop malignancy. The chances are lesser. So what do we do with this information? Implications for practice and research. So for practice is prompt identification. Every dentist, whether it's a general dentist or any other specialist, should be in a position to identify these lesions and diagnose them and refer them to an oral medicine specialist. And after that, the oral medicine specialist will follow up these patients for a long term and then ensure that the patient remains asymptomatic for as long as possible. Then in terms of research, well, we have a lot of clinical trials that have happened and that are also ongoing right now to provide relief to patients from lichen planus. But in spite of the best remedies, we find that it still remains incurable. But we need long-term follow-up studies to determine, to ensure that patients, if they're present with any malignant changes, they are treated early. So early diagnosis, if they develop a malignancy, it ensures that their survival rate is prolonged. So most important is takeaways from this session are, since we are dealing with oral cancer and since we're talking about malignant transformation of oral lichen planus, history and diagnosis are very important. And if a patient has a history of tobacco and alcohol dependence, then de-addiction counseling and follow-up in this regard is important. If the psychological status is a trigger for developing episodes of lichen planus, then these patients need to be referred to a therapist for follow-up. Medical management, depending on the severity of the disease, can go from symptomatic treatment and symptomatic relief to aggressive management of the disease to bring down the inflammatory process. Now, most important thing that I have observed in all these years of being a consultant is a lot of patients come to us with cancer phobia. Now, some of them or many of them have gone to a dentist outside and that dentist tells them, you are going to develop cancer. Now, I think this has to be handled delicately because we want to inform the patient that there is a likelihood, but we also do not want them to develop cancer phobia. And we know what any kind of phobia does to a patient. They can go into depression and that can even aggravate the lesion. So communication with patients is very, very important, and it takes a lot of skill in handling these kind of cases because a lot of these patients are already in some form of anxiety or depression. So patient education and counseling has to be handled quite adeptly. And I feel it begins with training undergraduates right from their 3rd year and 4th year BDS. Now, the Dental Council of India is introducing 8Com in its curricular revisions. So let's not wait until that comes. We can start training our undergraduates from right now on how to handle these kind of cases, how to deliver this kind of news without aggravating anxiety or depression in them. The point is also to motivate them to return for regular follow-ups and also telling them that it's an incurable condition, but with the right lifestyle choices and with prompt follow-up, they can live a good life. Their quality of life does not have to be that bad. Follow-up has to be long-term. So recently an Italian study was published where they have followed up patients for almost 30 years. So I'd say that any patient who is diagnosed with lichen planus should be called at least annually for follow-up to observe if there are any changes. If the patient is doing fine, then it's a great thing, but they still need to come every year for follow-up. But if the lesion gets aggravated, then promptly perform a biopsy, especially it's more of a red component, and then do the needful after that. So with that, I come to an end of my presentation.
Thank you, ma'am.
And yes. So if there are any questions, I'd like to take them.
Thank you, ma'am, for a very informative and eye-opening session, which makes us look out for more oral lichen planus cases. Now over to the chairperson's remarks. Dr. Rajendra Gowda Patil, can go ahead.
Thank you so much, Dr. Durga.
Thank you, sir.
And thank you so much, Vasanti, for a beautiful presentation. It was very crystal clear and very crisp. And then as we all know that lichen planus is a very complex subject, though oftenly we encounter them. It's easy to diagnose, not very difficult to diagnose, but very difficult to treat because it's a multifactorial, as you said, and then depends on a lot of factors. And then the situation, the systemic disease involved, stress involved, and the immunological mediated disease. So many things are there, and then so it has made it very difficult to treat. But right now, as you said, it is incurable. Somehow I feel that this word incurable is a little disappointing. So in the future, there is a treatment for that, but we don't know it. It's not incurable. It has to be cured, and then a day will come, then it becomes very easily curable. And then it is not only just applying something or giving some medicine. The whole individual, the whole patient psychology and the physiology and pathology, everything has to be considered. And then with all the advancing technology, definitely one day will come when it can be curable. So, but very wonderfully spoken. And then I'm proud that I was previously associated with all of you.
Hello. Hello, sir. You're not audible, sir.
Oh, some call came, that's why. So it was a wonderful presentation, and then I don't want to take much time because as she was very clear with her things, and then the malignant potential, about the malignant potential she talked. Earlier it was considered to be very highly potential, but of late many things are there, and then the disease is more persistent. Patients keep on coming and going, and then we have been seeing patients for many 15, 20 years. They are not developed cancers, but disease is very troublesome. Thank you. Thank you so
Yes,
much.
Thank you, RP, sir. Thank you, sir. Thank you,
Thank you,
Vasanthi.
Durga.
Thank
Yes.
you. Thank you.
Thank you, sir.
Thank you, Vasanthi.
We are going on to the next session. I would like to introduce Dr. Jitendra Barania. He's a consultant at the Surgipath Diagnostic Pathology Lab at Indore, in charge of this lab, which is there in Indore, and has developed management skills, histopathology, cytology section in the same institute for more than 4 years, and is managing this lab. And his topic for today is tissue sampling: when, what, and how. Now, the chairperson is Dr. Pravesh Mehra, and he is a HOD and Director Professor of OMFS at New Delhi. His special interests are oral maxillofacial trauma, TMJ surgery, orthodontic surgery, and he has worked at Maulana Institute of Dental Sciences and awarded a fellowship of Indian Board of Oral Maxillofacial Surgery, advisor to the WHO and Government of India on oral health and dental education, on board for task force for the National Oral Health Program and other programs of the Minister of Health and Family Welfare. He's instrumental in designing and running the dental oral health IVRS helpline for the Ministry of Health. Over to Dr. Jitendra Barania, the speaker. Go ahead and throw some light over the topic, sir. Thank you, sir, for coming in.
Thank you. Thank you very much. Good evening, everybody. And thank you for inviting me.
So I would like you, please kindly adhere to the timing, as we are running short of time. Thank you so much.
Very few slides and very few things, because I already
that will be short and sweet.
I
Thank
have
you, sir.
already spoken on these topics.
Yes, sir. Thank you.
To just introduce some slides about histopathology, how histopathology makes it different for leukoplakia and dysplasia and invasive carcinomas. That's all. Rest of the things have already been covered by all the speakers. Thank you very much. When has to be done this tissue sampling should be when, what, and how. This is the topic. And when it has to be done as early as possible, when it has been, is there any lesion in the oral cavity, it has to be biopsied as early as possible. When it is most of the time dentists, most of the time ENT surgeons, and patient himself comes to the surgeon, and that time, if any lesion is there in the oral cavity, it has to be biopsied. That is the thing. And once it has been biopsied, it has to be sent to histopathologist for confirmatory diagnosis, whether it is a leukoplakia or dysplasia, because most of the leukoplakia, when they don't have any correlation with the tobacco chewing, they are benign. But whenever they are related with the, most of the time when related with the tobacco chewing, or a patient who is addicted to tobacco chewing, they get some amount of dysplasia, and most likely they are going to convert into carcinoma. But the patient who don't have history of tobacco chewing or smoking, they those cases, it is very rare to get leukoplegia to convert into dysplasia and carcinomas. Next. That is one of there are many things. Biopsy can be done directly endoscopically, and sometimes it is required for image guided, especially when there be patient present with the metastatic disease, like having a lymph node metastasis in the cervical nodes, or they are very close to the vessels or some crucial organs. So at that time, image guided FNAC has to be done. And in FNAC or needle biopsy is also suggested in this case, but needle biopsy in the head and neck areas is always require image guided. And FNAC, they are regularly doing in FNACs, even in cases of where there is a lesion intraorally, where the overlying mucosa is intact. In that case also, we are doing some FNACs in the intraorally. And we got few cases. I have reported many cases in some cases where there was a lesion intraorally, and which has been diagnosed as a small cell carcinoma or some sort of salivary gland tumors, which are submucosal. So another thing is scrap cytology.
Request you to kindly mute yourself.
Please.
Please don't disturb the speaker. Other than the speaker, please mute yourself. Please don't disturb the speaker.
So scrap cytology is the third way, and which is quite common nowadays. Many times, just to save the time for the patient, so for that the patient get very early diagnosis. Especially if you will get patient comes to for scrap cytology, we just do it in scrap cytology, and within 6 to 7 hours we can give the diagnosis. That is one of the common, especially scrap cytology is helpful in cases of oral cancers where the oral ulceration is there and some advanced disease is there. Or in that case, it is quite easy to do it on scrap cytology. The basic concept is of similar to like FNAC and cytology. Once you will get the slides on the pap smear, like in pap smear, we will get the scrap cytology also. Then proper preservation, the most of the time, but I got in a public in my laboratory or anytime wherever I studied, most of the time the problem comes when the specimen taken by the dentist or ENT surgeons, they don't put it in the proper preservation. Formalin solution, it should be transported in a proper 10% formal saline. When many times the specimen comes to us in a autolyzed state, which we don't get proper orientation, proper preservation, so that there will be no histopathological confirmatory diagnosis can be made. Even though the patient have a disease, we cannot produce or we cannot reproduce it on the report cards. So the proper sample preservation of the sample is must, because histopathologist or pathologist get only the sample, not the patient. We cannot report on the presentation of the patient. We report on the slides, and slide is like every slide is having a living patient behind it, and we report on the slides. So slide is once we'll get the material on the slide properly, after good processing, good preservation, then only we will be able to report it properly. Then biopsies, different type of biopsies we do. The routine means a lot of times when there is a doubtful reports are there, frozen section can be done. And routinely biopsy is being done with specialist hematoxylin eosin staining. Special staining is also helpful. Immunohistochemistry, like many times we get a dilemma type of report that whether it is a really carcinoma or inflammatory atypia, or it is just a mild dysplasia, or there is an invasion or not, microinvasion or not, and that can be ruled out with the special marker, immunohistochemical markers. Though I'll just present some slides on the here. This is a case of a leukoplakia. You can see this. There is a hyperkeratosis. Means the keratin material here is very much thickened, and not only thickened, but the problem is here the problem is the nuclei from the cell is persistent in the last keratin layer also, but there is no dysplasia, there is no abnormality seen in any of the cells here also. You can see here also and in this also. These two are the cases of leukoplakia. Next one is, you can see the differentiations, clear-cut atypia, clear-cut abnormality in the nuclei of all the cells, almost all the cells. It is severe dysplasia in this case, bordering to reaching up to the squamous carcinoma in situ. And all the layer up from here bottom to top, all the layers are having malignant cells in this. And this is a case where very early invasion started. Or you can say it is a microinvasive, because microinvasive, according to definition, it should be less than 0.2 millimeter. And it is definitely on microscope. I have calculated it. It is less than 0.2 millimeter, 2 millimeter less than 2 millimeter. Invasion is there. So it is a microinvasive squamous carcinoma. If any questions are there, I will be happy more, because this is another case, the submucosal fibrosis. You can see the almost above cells are showing some dysplasia. Some cells which means not dysplasia, but all the cells are having nuclei in the top to the top level.
The slides are not visible, sir.
Yes, slide. 1 minute. Yeah. So okay. See
Yes,
this.
sir.
Yeah.
Yes, sir.
The nuclei are there up to top level. So it is a lichen planus type of thing, like a leukoplakia type of thing. But you can see this dense fibrosis. Dense fibrosis again here in the submucosa. This is a case of submucosal fibrosis, where we always this type of cases where the submucosal fibrosis with leukoplakia is there. These are the most common cause because of tobacco chewing. The tobacco chewing or betel nut chewing or something, because of all this bad hygiene of the oral cavity causes all this submucosal fibrosis, and most of these cases gets converted into the squamous carcinoma. So this is all from my side. If you have any questions, you are there, you want on this pathology part, I can.
Thank you, Dr. Jitendra.
I think I just try to as short as possible.
Yes, sir. Thank you so much for that.
Yeah, thanks.
Yeah, thank you, Dr. Jitendra. I think,
remarks.
Yeah, thank you, Dr. Jitendra. I think an excellent presentation, a crisp one that you gave,
sir, very nice.
Describing total what, where, and how techniques for tissue sampling there. And I take this opportunity to thank my friend and guide, Dr. Reena Datta, the academic director, for giving me opportunity there. And of course, Dr. Pawan Gupta and his team with Shruti Agarwal, Rishabh Agarwal, for having the vision of creating ICanCaRe. And this time, like they started last time with Chota Dana, this time they have it come with do it, but do it right. I think it's very important when you talk about the sampling tissues, as we were discussing, Dr. Jitendra, present there. There are various types of sampling can be done, of course, but the gold standard evidence-wise, still, it is an incisional or an excisional biopsy that is required. Of course, neotherapies, salivary diagnostics with your liquid biopsy and other molecular markers are into the market, and they are being researched around But still, to this day, I think the biopsy remains the gold standard for diagnosis and to further manage these diseases, as you say. But I think before I go ahead, I would like to mention here another very important initiative that Ministry of Health, our Director General Health Services, Dr. Atul Goyal, has taken in a major way, where he has himself taken out a letter and a plea to all the medical folks that during your medical conference or the workshop, whatever may be, I think we should give it a thought of consuming alcohol, because alcohol is a major risk factor also in all these cases of oral cancers and pre-cancers there. So I think the initiative should be taken in a positive way in the fraternity, medical fraternity, as well as the dental fraternity, and we should set examples to the society as a whole. But one thing I would like to add on to what Jitendra was saying, of course, the diagnosis, of course, is biopsy, but I think the screening is a major role there. When you screen lesions of oral pre-malignant lesions there, and there the patient doesn't have any problems. So we should incorporate our dental surgeon colleagues, dental colleges, dental department of medical colleges in a major way, where opposite screening can be carried out. Because you see, dental surgeons normally get patients and they do it for the drilling, filling and billing part of it. But the lighter part of it, the soft tissue part or the mucosal part, nobody cares there because money is not getting paid to them. But the practice, if we change that and we change the attitude to handling these lesions and provide patients initiative there, it could be with self-examination of oral cavity when the patient has no problems, or when he just sits in the OPD and he's come for a normal filling or some dental procedure and we see a white patch or red patch, we should talk with the patient, counsel him. I think that is more important, because you've got to play a role not as a therapeutic person or treating that person from a dental colleague point of view, but yes, as a caregiver or as a sympathizer to the patient, or set an example to him for the management of his lesion, what he's had there. And then only we can do it, but do it just right. I think with that, I would like to conclude. Thank you, Dr.
Thank you, Dr.
for giving me the opportunity to talk about it. And thank you so much.
Thank you, Dr. Pravesh. Thank you, Jitendra Barania, Doctor.
I don't think there's any questions there for Sir. Is there? You have the nail on the head and bigger response to dentist. Yeah. Thank you for the informative sessions. And I think excellent slides. So I think it goes ahead. All hats off to Dr. Jitendra for keeping crisp and short. Yeah. Thank you so much.
Thank you, sir.
So this is where the oral medicine specialists and oral physicians play a role, that we see all the different lesions of the oral cavity, and we get to tell the patient that these lesions are there in the oral cavity.
Yeah,
thank
you're
you,
perfectly
sir,
right, Dr.
Pravesh.
Durga. Yeah.
Yes, sir. Thank you, sir.
Yeah,
Dr.
thanks a lot.
Pravesh and Dr. Jitendra. Now coming on to, I would like to give the dais to Mrs. Shruti. She will take it forward from now onto the paper presentation of the students. I will stop sharing my slides.
Yeah, thank you so much, Dr. Durga. I would quickly like to take forward the discussion from here. Thank you so much. So we have two competitions in place, the quiz competition, which is right after the panel discussion. And second, we have the paper presentation competition open for all the students. So there are 3 categories. 5 best papers will be chosen in each of these categories. The submission starts from today. The last date of submission is 20th. I'm going to talk more about this later after the panel discussion, because we are running short. And I would now quickly move on to the panel discussion for the evening, because we have a very prolific audience and the stalwart audience who are going to talk on these topics today. And the most important discussion, that yes, we have to do everything right on all these aspects. So now I take this privilege to invite our moderator for the evening, Dr. Somesh sir, to take the panel discussion ahead. Here's our chairperson for the evening, Dr. Murthy Remila. He's the head of project management, UR Rao Satellite Center, Bangalore. He's also the honorary secretary of Telemedicine Society of India. Sir has been a former scientist at ISRO. Here are our panelists: Dr. Rajiv Sharan, senior consultant, HOD, head and neck surgical oncology; Dr. Vishal Chowdhury, director of surgery; Dr. M.K. Sunil, professor and head at ICanCaRe Mahavir Dental College; Dr. Arul Sri Kenneth, oral pathologist, MBA, PhD biotechnology. Dr. R.M. Lalita, former professor and HOD of OMFS at Faculty of Dental Sciences, Ramia University. Dr. Malhar Patel, consultant radiation oncologist from Maringo Sims Cancer Center, and Dr. Apurv Shah, MD pathologist, histopathologist, Unipath Specialty Lab, Ahmedabad. So over to Sumesh sir to kindly take the discussion ahead. Thank you.
Good evening. We are starting about 20 minutes beyond our completion time. So we'll try and run it through as fast as we can. Dr. Vishal, I believe, is not available anymore because of the time lapse. Can I share screen?
Yes, sir.
Can you see my screen?
Yes, sir, visible.
Okay. Thank you for introducing my panelists. So I'll skip that part. The only change is that I thought that Dr. Murthy, instead of just making the final comments as a chairperson, I would probably invite him somewhere during the discussions as well to make some comments in between, and we'll have the benefit of his expertise during this session. So just to introduce the topic, this topic is about oral cancer screening. The relevance and the evidence I will just briefly present to you. According to the criteria for appropriateness, oral cancer in India is very appropriate for screening. In fact, the government has recently announced that it might make cancer itself, all cancers, notifiable disease. The fact that it can be effectively screened was definitely shown by the Kerala oral cancer screening trial. In brief, it screened close to 1 lakh individuals, 95,000 odd individuals, and showed that there was about 27% reduction in oral cancer mortality. This happened after 3 proposed rounds of screening, but then only the average round of screening was 1.7. So it's a little difficult to screen large populations. So that would be a point I would like to discuss, whether we should only rely on government agencies and public facilities to do the groundwork for us, or people like dentists and ENT surgeons, maxillofacial surgeons, who are the first point of contact for many of these patients, should actually get into the screening. The study also showed that it is more efficient to screen the high-risk population rather than the population at large. And it needs to be linked with a subsequent care in terms of biopsy and treatment. So then only we can bring about a reduction in cancer mortality. But then the practice of screening from public platforms, the NCCP ran for 4 decades and or 3 decades around, and then it was replaced more recently about a decade back by the NPCDCS. But the last report says that we have probably not been able to screen more than 10% of the target population. So there are ground realities, and there are a lot of gaps in the proposed bringing down mortality from oral cancer by screening. So I would ask my panelists on these main points, define and identify the high risk, because that's the group which screening appears most efficient. How to train people to do the screening. Obviously, it's not just doctors and second level, third level specialists who are doing this. Is there any technological advancement which can improve upon the results and the coverage? And how do we use our resources in a more cost-effective way? So I have marked the appropriate issues for the speakers. And I would like to start. Dr. Vishal is not here, so I would request Dr. Lalita to tell us what would be a high-risk individual, who would be a high-risk individual for oral cancer.
As we all know, high-risk individual for oral cancer is who is a tobacco user, may it smokeless or with smoke, and then complied with the alcohol, and then the gender, then the age, and the UV light, and the poor nutrition. And then as a dentist, I would like to highlight the importance of oral cavity screening for any ill-fitting denture or a sharp tooth which is causing a traumatic ulcer, and later they go in for oral cancer. But by and large, the high risk is the tobacco. Tobacco is the killer.
Yeah, thank you, Dr. Lalita. So that is what the Kerala trial also said, that users of tobacco and alcohol form a distinct group which can be targeted for screening, and that overrides all other parameters. The NPCDCS proposes to screen only individuals above 30, but we know that a lot of youngsters use smokeless tobacco starting in their later years at school, and we know that smokeless tobacco can cause cancer at a very short interval. So age is really not a bar to start screening. Anyone who has or has been using, had used or has been using tobacco or alcohol is a high-risk subject. Dr. Arul, can you tell us a little about oral potentially malignant disorders? Are they, how risky are they? Do we always get to see these pre-malignant conditions before development of an oral cavity, oral cancer, or this particular phase may not be seen at all, and patients may develop oral cancer straight away?
Good evening, sir. Good evening. These are called potentially malignant disorders because they have the potential to develop into malignant transformation or malignant transformation. And we know the few potential malignant disorders: leukoplakia, proliferative verrucous leukoplakia, erythroplakia, oral lichen planus, oral submucous fibrosis, acne colitis, and palatal lesion associated with reverse smoking. And these are few potentially malignant disorders. So they are potential for malignant transformation. Unless they stop the habit, definitely this will progress to malignancy.
So do they progress faster or more definitely in individuals who continue with the habit, or that is once developed, it doesn't matter whether habit is continued or not?
If they discontinue the habit, there is more possibility for regression. If they continue the habit, more possibilities are for malignant transformation.
Thank you. Would you say that unlike in cervix, where we have a distinct progression phenotype which can be identified between the normal cell and the cancer cells, CIN1, CIN2, CIN3. In many oral cancers, we may not actually get to see those pre-malignant conditions or states. And that is why it becomes even more difficult to screen and bring down the mortality from oral cancer.
So in this, how it develops, initially, histopathology, we can see few dysplastic cells may be there. We say mild, moderate, severe grade. Mild dysplasia, restricted to lower 1/3 of the epithelium. Moderate dysphasia, till middle 1/3. Severe dysphasia, top to bottom dysphasia. Next step is carcinoma in situ. Top to bottom dysphasia with basilar hyperplasia. Next is breach of basal layer, basal membrane. That is invasion. So it grows step by step and finally ends in invasion.
Right. So so the implication is that all these lesions, they would need to be biopsied to know how far the changes have occurred, whether it's moderate dysplasia, severe dysplasia, and that would determine how intensely we follow up these individuals. Is it so?
Yes, sir. Yes, sir.
Okay. Dr. Apurva, you would be seeing a lot of specimens of resected oral cancers. Do you look at just the cancer, or do you look the surrounding areas, and do you communicate that to your clinician? Because we know that that all these patients with oral cancer are at risk of second field tumor, which occurs within the vicinity of the cancer. So over and above the margins that you report, what other findings do you report in the surrounding normal tissue?
So generally, we surrounding mucosa, we see, as doctor has mentioned, that dysplasia also, as well as many times we want to see submucosal fibrosis is there or not, because that can subsequently lead to cancer also in other areas also. So that we look for submucosal fibrosis also. We look for HPV finding also sometime, that karyopexis, basal cell morphology, P16, IHC can be positive in that. So certain findings we look in surrounding area also, in addition to invasive cancer.
Thank you. Dr. Rajiv, once you get a patient with, say, leukoplakia, erythroplakia, different types of leukoplakia, and oral SMF, lichen planus, do you have the same attitude towards dealing with all of them, or do you have kind of a categorical attitude towards managing different lesions? Which one would you intervene? Which one you would observe? Is there any role of oral antioxidants?
Good evening, Ramesh and everyone. Can you hear me?
Yes, but if you could be a little louder, it would be better.
Okay, so that depends upon types of lesion. So if it is homogeneous leukoplakia, then definitely we can observe these patients if it is homogeneous. But if it is heterogeneous, like speckled or verrucous or mixed with erythroleukoplakia or erythroplakia, these patients require biopsy to see like what kind of dysplasia is present or not. And these lesions will benefit if excision is done for these lesions, because there is high chances of malignant transformation will be there in heterogeneous leukoplakia, and erythroplakia, obviously it will be much more. So homogeneous leukoplakia may be observed, but if patient is apprehensive and wants to get rid of that lesion, so then excision can be done. But in other cases, heterogeneous and erythroplakia, definitely these patients require excision of these lesions.
Okay. For those homogeneous leukoplakias, what would be the risk of progression to malignancy, and over what time?
So for homogeneous, risk of malignant transformation, maybe it will be around 5 to 10% or 15%. But if you take heterogeneous, that will be maybe 20 to 30%, and erythroplakia, it will be maybe more than 35 to 40%. So because risk is less in homogeneous leukoplakia, that's why depending upon like if it is small or just limited to one subsites, then if patient is billing for regular follow-up, then we can follow up these lesions.
Now talking about subsite, are other than the appearances, are certain sites also more liable to progress, and these OPMD at different sites carry different risk of progression to malignancy?
Definitely, like tongue, lateral border of tongue, that chances will be more because that is also associated with repeated injury from the teeth and all. Similarly, like buccal mucosa on the occlusion line, there will be more trauma, and those like sharp teeth may be the reasons for leukoplakia in these regions. So definitely these lesions need some kinds of treatment, excisions, especially if it is heterogeneous.
What is the role of antioxidants?
A role, we don't know exactly what is the role because some patients may respond to antioxidant, but most important thing is causative factors that has to be stopped. So if causative factor is tobacco use or alcohol use, that has to be stopped. Patients should be counseled regarding quitting of these habits. And other than tobacco or alcohol, if sharp teeth is there, because a lot of these patients we see in the clinic, they come with repeated ulcer due to tongue bite or mucosal buccal mucosa bite, and later on after some time that comes with frank carcinoma. So apart from quitting habits, the grinding of the sharp edges, that is also important in these cases.
And possibly correction of any ill-fitting dentures, which Dr. Lalita mentioned, because those are any irritative agent, whether it's chemical or it's a physical agent like sharp teeth or ill-fitting dentures, they need to be addressed. Dr. Malhar, radiotherapy in the past to the head and neck area, what implications does it have for development of oral cancer?
So in development of oral cancer, in the theory, we do have evidence that radiation is one of the causes of oral malignancy, but the chances are 1 in 1 lakh or 1 in 1 or 10 lakhs. So previously received RT, and right now after 20-30 years, getting a second primary, I think the chances are pretty less. But definitely in past, radiation has a role in increase the fibrosis of the buccal mucosa and the oropharynx. So that might increase the morbidity of the patient with the I think a primitive radiation techniques like 2-dimension and 3-dimension.
Okay, so let me put it differently. Radiation possibly directly may not cause that significant changes to cause significant number of radiation-induced oral cancers or mucosal cancers, unlike it does for thyroid cancers. But
yes,
does radiation bring about some changes within the oral cavity, which brings down the mucosal defenses?
Yes, sure. In the past, there was no technique or the tool to save the parotids. So there were a very high chance of xerostomia. Recently, we are dealing with a good technique. So recently, we don't see much of a xerostomia in our setting. But definitely, if you discuss about the past, that changes the oral mucosa and the salivary function. So definitely, it has the implementation.
Thank you. That's an important point which I thought we must understand, that having normal salivary flow is important, and it's kind of a protection against malignancy oral cancer.
Definitely, sir.
Let us move on to, so we know that we need to screen these patients, the high-risk individuals, intervene with among those in whom we find oral pre-malignant lesions of the high-risk category, which Dr. Rajiv said. Now, how do we identify these pre-malignant lesions or frank lesions? Because we know that other than the delay at the patient level, there is always an element at the physician level also, so far as delayed diagnosis of cancer is concerned. So with that in mind, I would like ask my esteemed panelists, Dr. Lalita, Dr. Rajiv, Dr. Sunil, and Dr. Arul, in that order, to if you can see the questions on the PPT to address these issues. Is there a gap in awareness or alertness on part of the treating dental surgeon or the oral maxillofacial surgeon or the ENT surgeon? Do they need refresher courses? And should all of them undergo that kind of a training, that kind of an orientation program, or is that specialty also getting divided and only some need to focus on these areas? Dr. Lalita.
Yeah, definitely. There is a lot of division in the specialty. So some people focus on non-oncology and they would not like to involve in oncology per se. So definitely, I would like to say that we need to give an orientation program. Look, these are the things we would like to treat early, and then the message should be loud and clear that oral cancer can be cured if detected early. So why don't you help us in our mission? So this message should be propagated to the general practitioners, dentists, and because I have seen many of my patients who had come all their life to a neighboring department, and then they were perfectly all right in their health, but for the oral cancer. So whenever there is a habit history noted, and they have not done oral cancer screening, look, we are looking for an enemy in the mouth. This is my message, and you please refer it to me. This I used to highlight in my department. So this goes a long way in getting referrals for oral cancer. And then, yes, we need to address by refresher courses. Yes, I am very much for that. And then people should be trained for both screening, oral screening, and then train the patient also for self-examination of the mouth.
Does the Indian Dental Association or the Maxillofacial Surgeons Association run any specified courses for this?
We have no, I mean, I am not aware of any course like this, but they are insisting on screening programs and oral cancer prevention. Definitely, we are forming oral cancer screening as a priority.
Okay. So the message for all is that anyone who looks inside the mouth, the oral cavity, for any reason, must also, especially for users of past or present users of tobacco, gutka, areca nut, that's betel nut, pan, and all alcoholics, all those who have been past or present users of alcohol, they must be screened for oral cancers. This was also the message from the Kerala oral cancer selection screening trial.
So, means one thing.
Yes.
Yeah, so there is a lot, there is a lack of awareness on parts of just not only dentists, but also doctors like MBBS doctors. So I think that should be in the curriculum. So any BDS or MBBS or any nurses, if they are coming out of their courses, they should be able to diagnose, like if any ulcer is there in the oral cavity for more than 3 weeks time, that should be considered as cancer until unless proved otherwise. So this message has to be integrated in the course curriculum itself, so that any graduates coming out of their courses, they should be able to diagnose, because a lot of time we see like patient will be given antibiotics, antifungals, antioxidants for long time, maybe around 6 months, 1 year, till the time disease will be in stage 4. So obviously stage is the most important factor, most important prognostic factor for oncological outcome. So if we delay the diagnosis, that prognosis will be definitely poor in these patients. So awareness among the doctors, among the dentists, among the nurses are very, very important.
Thank you, Rajiv, for bringing that out emphatically. If you look at the NICE guidelines, they do have these red flag symptoms and signs for their general practitioners. That in certain cases, when with what kind of symptoms or presentations or kind of patients with different diseases, they should be sent urgently to the specialist. And we, all of us who practice head and neck oncology, see that a lot of patients with tongue ulcer or a loose tooth, they are observed and treated with other medications for a long time without even a biopsy. So there are certain telltale signs of malignancy. If there is a lesion, it needs to be addressed. Over and above that, even if there is no lesion, anyone who looks inside the oral cavity of any high-risk individual needs to look at other mucosal areas and see if there is something inside there. Dr. Sunil.
Yes, sir.
We see a lot of patients coming in with who got a painless tooth removed. They are not diabetic. They do not have a very bad periodontitis or tooth root infection. So just they had a floating tooth, and the dentist didn't suspect anything.
Exactly.
It was removed, and then much later they come with frank invasion of the mandible, and they have they need to get the jaw removed.
Yeah.
So I have three issues for you, if you can see on the screen.
Yeah.
Could you comment on that?
Good evening, everyone. First of all, I would like to continue with the previous question. There are a lot of healthcare workers, and the Indian Dental Association of the national branch and the state branches and the district branches are conducting a lot of oral cancer screening camps, as well as awareness in the schools, in the government schools, as well as in the public, etc. So even though conducting so many camps and other things, screening aspects in the college level, institution level, the hospital level, but still there is a lacunae. So I think still the awareness has to be increased in a different way, or in a more number, in a more of organizations. And nowadays, I think the Rotary Club and the Lions Club organization are joining hands with all the Indian Dental Association, and they are doing a better work in screening the camp, particularly to differentiate between the pre-cancers and cancers, lesions, and the motivation. Even though some of the camps, I think the college level, they are doing the screening camp, then getting motivation, they are distributing the pamphlets, explaining the things, etc. So I think these are the implications, but still it's not sufficient. Comes to my my point of view in the dental imaging. Yes, see, when we talk about the lesion, particularly in a chronic deep ulcers, there is a slight involvement of the bone. See, on a clinical examination is a mandatory for us. How do you going to, and the involvement of the lymph nodes. Suppose your examination, if you feels that there is a involvement of the bone, if the deep ulcers, particularly in the buccal mucosa, retromolar area, where the patient always says inability to open the mouth. So we can think that there could be involvement of some masticator muscles also. So that cases, yes, there could be use of an imaging, unless your examination should be good. If your examination is in lacunae, you cannot advise any imaging. You feel that it doesn't require. So I say that it is underused. I can't say word, it is misused. I prefer to say unused, because the lack of examination is deficient by the healthcare worker. It could be anyone. And second point that there are certain imaging techniques. If there is a involvement in the bone, definitely the first line will be the digital imaging, where we can know about the involvement of the tooth. If there is an involvement of the tooth and certain bone loss has been there, and tooth appears to be loss of lot of characteristics on radiographically, lot of all the supporting bone and everything, clinically, you feel that there is a mobile tooth, and the person who is going to treating may say that it is a simple mobile tooth and tooth. So I suggest that any loose tooth, whatever you feel, or if you have any history of tobacco, history is there, definitely you have to go for an intraoral radiograph, simple radiograph imaging to know that what is the status. Then you can correlate with the clinical and radiograph to come to conclusion. The third point is, yes, we are not, I can't say that CT scan, okay, only a few cases. If it is the involvement of the bone in the multiple quadrants, or if it is invaded, particularly in the palate, if it is invaded into the interior structures, so we prefer to go for a CT. Instead of a CT, I think most of the specialists, oral dentists are in the group, they prefer to go for a cone beam computer tomography. We call it as CBCT, where there is a less exposure compared to the CT. So we prefer that, and that is coming to the team. In addition to that, before imaging, some of my friends, they are in the process of doing certain sensors. The sensors have been used to detect that the early stage of these cancers, and they are going to the team. And the sensor has been, it is with the help of artificial intelligence, it has been attached to the mobile, and you can screen it and you can get the data, and the data has been collected and giving awareness to that. So this is a doing along with some local organizations, followed by the social welfare organizations and the hospital and the college together. They have started in few areas in Karnataka. So probably if it is successful, then maybe that particular device and the tool of AI, it will be helpful for all over the country, and it will definitely, any one person can go on screen. It doesn't require a big team to go and do. So that is probably one message you would like to add in that.
Thank you. As you were talking, one more point came to my mind.
Yes.
That when a radiologist sees an empty tooth socket, it is all a matter of interpretation, whether it is because of tooth root infection and extracted tooth, or is it because of actually invasion by oral cancer. So that interpretation is very important. And I think we need to educate people about the radiological interpretations, especially in absence of a histopathology, just to interpret that it is just because of a tooth root infection when there is a clear osteolytic lesion, erosion against osteosclerosis. As I think those are the things which must not happen.
Exactly.
Dr. Arul, are the appearances of the clinical appearances, the naked eye appearances of malignant lesions so much overlapping with benign mucosal lesions that it's very difficult to make them out? Or would you suggest that anything which looks abnormal must be followed up closely or biopsied? And what would be the indications for biopsy?
So regarding this clinical pathological correlation, the clinical diagnosis would be leukoplakia, maybe leukoplakia or erythroplakia, whatever it is. But our histopathological diagnosis will be either presence or absence of dysplasia. If dysplasia is there, whether it is mild, moderate, or severe, or carcinoma in situ, or invasion. So the clinical diagnosis will be different. The pathological diagnosis will be this. This is the pathological diagnosis. Whatever the clinical diagnosis may be there, the pathological diagnosis will be presence or absence of dysplasia. If dysplasia is there, whether it is mild, moderate, or severe, or carcinoma in situ, or invasion. Next, another one thing, sir. When we receive the specimen, we need proper clinical details. Why we need proper clinical details? Some people will not send us proper clinical data. They say they are pathologists. They have different eyes. By seeing the tissue, they should give diagnosis. they should not send them proper clinical diagnosis, but proper clinical details. It is wrong. I shall quote an example. There's a condition called necrotizing silometaplasia. It is 100% benign self-limiting lesion. Necrotizing silometaplasia. But histopathologically, it mimics squamous cell carcinoma. Unless clinical details, proper clinical details are given to us, we cannot diagnose that as a benign condition. Actually, it's a benign condition, but histopathologically, it resembles squamous cell carcinoma. So the clinical pathological correlation is very much important for proper histopathological diagnosis.
I think you made an excellent point, Dr. Rahul, that we need to work together. We need to work in unison. Otherwise, we'll all end up with the 5 blind men, which cannot come to a logical conclusion. I think with that, we cover most of the important areas, which a first point consultation specialist, whether it's dental, ENT, or oral surgeon, general practitioner, they must be aware of and must act upon this. But so far as oral cancer screening is concerned, a lot of the activity of screening is actually carried out not by specialists, but by paramedical and untrained staff. So I'd like to address these issues here. In absence of Dr. Vishal, Dr. Lalita can take up that first point, that we have a lot of nurses. If you look at National Cancer Grade publication from Tata Memorial on screening for cervical, breast, and oral cancers, these people form an important part of the screening program. So should we also be looking at training all our paramedical staff? Because they spend more time with the patients, with the relatives, and they are better equipped to help with opportunistic screening.
Also, ORX, they have developed some.
Yes, definitely this training the healthcare worker, whenever in the absence of infrastructure, the patient reaches a healthcare worker for a different problem. Then if he was noted to have a tobacco history and comes under the high risk category, and they are the people who should
we have lost your audio.
Dr. Lalita, you're on mute.
So the healthcare workers should be trained to do the basic examination of asking the patient to open the mouth and then look for any problem, any change in the color, texture, or any bleeding in the mucosa and the mobility of the teeth. So this basic concept, if they are trained and they can tell, look, you have some change in your mucus or the soft tissue part, and then you'd be referred to a dentist, or you are referred to a oral surgeon or an oral medicine, or preferably a dental college setup. Then this will add. So this training consists of basically ask the patient about tobacco use, alcohol use, and educating them on the harmfulness of tobacco, and then being aware of certain symptoms which is given as 7 warning signs, like non-healing ulcer, white patch, red patch, anything, and swelling in the neck.
So the message is, if I may sum up, is that they need to be trained about who is a high-risk individual and what is a high-risk oral appearance.
Right.
Right. And the use of graphic materials to pick up these lesions.
Yes, we also provide brochures I was working in an NGO, so I used to provide some brochures as to how a white patch looks, how it is non-scrapable, and how a red patch looks, or how a non-healing ulcer looks, or a neck swelling appears. So this is a pictorial representation, gives them a input as to what they should look for.
Right. Dr. Malhar, we know that about 4 to 5% of patients who are cured of their index cancer go on to develop a second cancer every year, 4 to 5% per year. So at the end of 5 years, nearly 20% of our cured patients come up with a new lesion, which could be a second field tumor or a second primary tumor. We know that radiation also brings down the mucosal defenses, and many of these patients have had radiation. Do you see a lot of second cancers coming up? Do you feel that patients who have already suffered from oral cancer are at a much higher risk of developing a second cancer, even 3 years, 4 years, 5 years down the line, when they are declared cured of their index cancer? Is it time to leave them, or is it time to continue surveillance, and how?
Yes, sir. So it is definitely time to continue the surveillance, whatever the stage of the disease, because we have seen the second primary or the field cancerization in early or late stage of the cancer, definitely. And with the newer techniques, we can preserve the saliva, so the flora of the mouth is somewhat preserved, and a patient usually gains the taste and the reasonable salivation after say 1 year of the treatment. So if you are saying 3 years or 5 years down the line, the radiation effect won't be present in the oral cavity, so that oral mucosa will be as good as the normal mucosa. But the issue is with the tobacco, the habits of the patient. We all know that the tobacco effect remains in the body for more than 1 or 2 decades. So definitely we should not leave our patient. We have a habit of continuing examination of the patient. We advise lifelong follow-up for those patients who are at high risk of developing SPT or SFT.
Right. So as I explained to my patients, that in the initial years after the treatment of your oral cancer, the follow-up and examination is to look for an early recurrence, which could be salvageable. Mostly it is not. But in the later part of your follow-up, because most of the recurrences would come up within 2 years, 80% of recurrences of oral cancer post-treatment come up within 2 years. So in the later part of your follow-up, we are looking more for second field tumors, second primary tumors, than the actual recurrence of the index cancer. And it is to sensitize the patients themselves for self-oral examination, and because they know what a cancer looks like, they can possibly pick up these lesions early. We must remember that these cancers often come up even in between our office visits, and that is why they should not be totally dependent upon the doctor. So these second field cancers, second primary cancers, also need to be included when we talk about screening and prevention of oral cancers.
Yes, one more point. When we have a T1 disease or per se T2 disease of the oral cavity, and radiation was not advised, adjuvant treatment was not advised, or it was not required, in those patients also, see, patient becomes relaxed that my cancer is in stage 1 and I don't need adjuvant treatment, so my chances of recurrences is very less. But he will continue the effect of the tobacco he has eaten in the past.
So definitely those patients also, we should not encourage them, or we should encourage them to for the lifelong follow-up.
Thank you. And at this point, I would like to bring in our chairperson, Dr. Murthy. We see that so far as public population-based screening by public services is concerned, they are largely carried out by ASHA workers and in rural areas and peripheral centers, where they may not have specialists who are trained to identify immediately on first glance what an oral cancer or an oral pre-malignant lesion looks like. So for the training of these untrained healthcare workers, they have absolutely no medical background, but they have intense motivation. How does technology, especially with your access to ISRO and telecommunications, how do you think that it can be beneficial?
Yeah, good evening, sir. I'm going through the presentations and then the discussions on the identification of the lesions and other medical aspects. First of all, I'm not a medical doctor, but a doctorate in the technology side.
Right, sir. But, we understand that.
Yeah. But what I would like to focus is, some of the speakers were telling that there is less attention in the oral cancer and also less number of specialists. So definitely this is the area where the telemedicine and the telementoring and tele-tutoring the paramedics or the field staff will be useful. And also the telemedicine can be used to upgrade the dentist slightly above the regular dental observation and examination to a predetermination or at least a guesswork before they get into the malignant situation. And as far as your question of getting into the villages and the helping the ASHA workers is there, nowadays most of the places the connectivity something or the other is available, and they can do that. And wherever it is not there, and also there are many carrying kits like suitcase models and backpack models which have come. They can go collect the samples of the rural patients where really there is no connectivity. They can come back to the office like our electric meter readings. They can come back, connect to the server at the office in the evening, and that can get populated to the doctors and they can give an opinion. Probably these ASHA workers can make a second visit and identify the people who need to be sent to the specialist end or who need not be worried, etc. Unfortunately, the government is not banning these bad products like the gutka and other things, and simply writing an 18 font size injurious to health, and then you people all have to struggle to tutor them and train them and educate them with the ill effects. Okay, that is not in our hands. But I appreciate the effort of Pawan Gupta and the team in organizing this specific theme for 1 month long for 4 weeks, and many of the specialists coming through. So I summarize the answer to your question as, wherever it is available, they can carry a backpack model or a suitcase model kits wherever it is available. And in real time, they can show to the doctor at the other end and then decide the next course of action. Otherwise, they can take pictures and then take the saliva or whatever samples required, come to the base station and then analyze them and then take the second step. This only needs people to go to the second time. And for that to happen, we have to train these people. That can happen in centralized locations from a tertiary hospital to a urban villages, or they all can be called once per week or so, or one time for 1 week education, how to examine, how to suspect, and then where not to take a chance, etc. And that should enable them as a good field worker.
Thank you, Dr. Murthy, for that input. So basically, we are moving on to from just visual inspection to a machine inspection with a handheld device. And moving on further, I would say that a lot of these handheld devices are going to be accessible to person. I mean, people themselves. They would not even be dependent upon a healthcare worker visiting them to take these data to for data acquisition. And with the health, the digital health mission coming up, many of them can upload these data directly onto their own case files. And I think those are promising areas, and they can really help in bridging the gap in missing out early oral cancers.
Yeah, I would like to take 1 more minute, sir.
Yes, sir.
Yeah, we have a telemedicine society of India where many doctors, paramedics, students, and medical institutions are there, but very few oral oncology people are there. And earlier, when ISRO was running, actually, I'm still in ISRO service for 2 more years. When ISRO has started this telemedicine service, we had one network called Onco Network, connecting the RCCs alone. So now, like that, if some of the oncology specialists and oral oncology specialists, if you come on board the Telemedicine Society of India as members, we can have one wing specifically for the oral oncology and then spread the awareness and treat, and not directly treating, because you are less numbers, you cannot treat all the patients. So you can train the other doctors or the other specialists, as I said, and enable more number of specialists or at least semi-specialists to screening, to say. So I invite all of you after this session to join Telemedicine Society of India as members and share the knowledge and become a part of the network.
Thank you, sir, for that information and that invitation. I suppose all the viewers have got that message loud and clear and can participate in the program. Any further words on training before we move on to the next topic? Dr. Lalita, Dr. Rajiv, Dr. Sunil.
No, on training, the sensitizing the community, importance should be given for health promotion program, then specific protection from irritants, and then mouth examination, and then referrals, and then spread the news, like nowadays they spread the news about breast cancer, pink awareness, like that. So raise awareness about risk factors, share survivor stories, encourage people to become an ambassador of prevention for oral cancer, and then take part in regional fundraising events for supporting the oral cancer patients who are economically very low, and to support them, these fundraisers. So when we create an event like that, the community becomes aware that yes, there is something called oral cancer and it can be treated.
Those are excellent tips, Dr. Lalita. Rajiv, do you have anything to add to that?
I think Dr. Lalita has covered most of the things. So I don't.
Because this is from my experience, and
yes,
I have
it speaks. Your message speaks that you have worked on the ground, and this is what the field work has taught you, and these are very important messages that you are giving us.
Yeah, because this is my life experience on oral cancer treatment prevention.
Dr. Sunil, would you like to add?
Sir, I would like to add after what Madam said. So where we have to collaborate with the various organizations where the dentist or a oncologist or a OMFs or any person, we have to join with the hands and try to go for the rural areas and do the awareness about the oral cancer. This is one point which I would like to add. And now we are in the digital era. So we have certain sensors, certain devices has to be, which is to be connected with the Android mobile, because Android mobile can be used in many things, in many ways. So if that AI, if we with the help of artificial intelligence, we could have do that, taking a photograph and giving and sending a message to the, as sir said, Murthy sir said, you can send it to the concerned oncologist or oral pathologist. This is what to be done. So definitely, I think we'll get in a more of awareness, and this could be done now, because most of the people are using the Android mobile. So this can be taken as a positive note, and we can create some awareness among them, and we can create a group, and the message what we have, what investigations to be done, and how long the treatment to be done, all those things we can convey to the patients and healthcare workers also. So it will be more helpful for the public.
Yes, so we need to use technology more and more.
Sir. Exactly.
Actually, just for information, the FDA has approved a handheld device for breast cancer screening.
Exactly.
And which is which has been shown to be as effective as conventional mammography for early detection of breast cancer.
Okay. Yes.
The problem is that we need to look inside the mouth to know what are the changes. In one of our visits, in one of our camps, this is what we do. We used to go with a pro forma. So these are all prospectively acquired data. And this was a small screening camp of 117 subjects, where we found that 52% were users of tobacco or gutka. Among the non-users, the mouth opening was adequate in 95%. But in the group with just 5 years of use of tobacco and gutka, only 2.5% had adequate mouth opening. And in fact, about 1 out of 8 had less than 1 centimeter of mouth opening. So this is the problem with oral examination, because trismus, limited mouth opening, this prevents adequate oral examination. It prevents appropriate dental assessment, dental treatment, and oral hygiene. In fact, we found that these patients with limited oral mouth opening, majority, at least half of them, had very poor dental hygiene. So this is the ground reality. Unlike in the West, where they do not have so much of OSMF, we face a different set of problems altogether. And with that in background in mind, I would ask all of you to comment on this. So is oral visual inspection enough? Or in the presence of bad oral hygiene, periodontal infection, oral inflammation, we need something more, maybe autofluorescence or NBI or whatever. Do we basically need some technology-based devices, aids to help us in diagnose oral lesions? There is a lot of market, I mean, Wellscope and Horoscope, and there are a lot of things.
Yeah.
So I would like you to start with Dr. Rajiv. You can take the first two, Rajiv. Is oral visual inspection enough, or do we need to supplement it? And how do you rate these various Wellscopes and other things? And do you think they are really useful for mass screening, or they are just still limited to the clinic?
So for like oral cancer screening, whatever studies are there, like all studies have used oral visual inspections alone, and that has shown good sensitivity and specificity in these for oral visual inspections with good positive predictive value. But at the same time, if patient has decreased oral opening, mouth opening, so obviously visual inspection is not sufficient in these cases, because a lot of subsites, especially posterior buccal mucosa or retromolar trigone, or like posterior part of tongue, you cannot visualize those parts. So that becomes a bigger problem in patients with some mucous fibrosis. So these patients will definitely require some other forms of examinations, instruments, like especially like if mouth opening is less, so all your scopes, what you are talking about, well scope or Vigilight, all these are not going to work because you are not, like, again, same thing, same problem will happen. So in those cases, patient has to be examined in a clinic with endoscopic examination. Then only you can visualize all the areas. And if patient is symptomatic, like if severe submucous fibrosis is there and patient is having recent onset of pain, then something going on, something wrong is going on. And these patients definitely require endoscopic examination with some forms of imaging to confirm that we are not missing some serious disease inside. And at the same time, how can various scopes help? So these scopes have been used as diagnostic adjunct, not as a replacement for visual inspection. So these can help you in taking biopsy from the lesions, which is more suspicious. So that gives you a hint which part of the lesion is suspicious, so that you can focus your approach, focus your attention to those areas and take biopsy from those areas. So there is a role of these scopes, but not at the screening level, but definitely latest technology like AI and all, if we integrate those things like mobile Android devices with fluorescence technology, if they can be used at mass scale, that will definitely help in oral mass screening.
Right. So we need to make a distinction between what we are going to use for screening and what we are going to use for a definitive diagnosis. Those, even mammography there is a screening mammography and there is a diagnostic mammography. Once you find a lesion, then maybe you can further try and understand more about the lesion with many of these scopes.
Sir, if
yes,
I may.
Please, Malan.
Yeah, sir, few surgeons are using this.
We've lost your.
For in a substitution of. Yeah, am I audible?
Yeah, now, but in between you tend to go off.
Yeah. So some surgeons are using well scope for the instead of a frozen section, they are using well scope, and they are using well scope for the taking the biopsy area also. So I just want an opinion of the house. How helpful it is.
I can tell for myself, I have not used the well scope, but we do use NBI with the flexible endoscope. For oral lesions, it is not, we generally do not need to use it. We use it more maybe for oropharyngeal and laryngeal areas to map out the tumor rather than for the precision diagnosis, because the tumor boundaries sometimes are not very precisely defined on oral examination, especially for very, for plain white light endoscopy for very small lesions. So in those cases, we would be using NBI. I would like Rajiv to chip in also. Using it in place of frozen section, I think that's a little area where I would be a little careful. Where I use frozen section, other than for margin assessment, is that if the biopsy had shown maybe carcinoma in situ or severe dysplasia, and it's a frank lesion, I would excise that lesion and send the entire thing for frozen to look for invasive cancer, because that has different implications for management of the neck, for getting adequate margins, all those things. So that is where I would rely on frozen section. I wouldn't rely on any endoscopic, whether it is OHT or whatever.
Thank you so much, sir.
Sir, I would like to, with your permission, I would like to give a comment on the previous question you said about on your survey. There is a limited of mouth opening where couldn't able to see that. So now we are coming out with this some custom-made devices where we can increase the mouth opening. So even I am also doing a study on that key to create a one appliance to increase the mouth opening so that we can treat some of the OSMF cases. So probably in few months, I may come out with the new appliance, a device type of the metal device, where you can increase the screws so that when the patient frequently comes to us, so you can increase the mouth opening. So that gives better so that we can do, because some of the treatment, poor oral hygiene, all those things are keep an end. So that not be an end point. So these devices will make us to do some treatment, at least to remove the causative factors. So,
so we certainly need to supplement
exactly,
our just clinical examination.
Exactly.
That can help.
Yes, thank you.
We had a long talk on saliva-based tests. So if you need to make any quick comment, Dr. Kenneth, you are invited. You are muted. You are muted. Unmute yourself.
So regarding saliva-based tests, saliva testing is emerging as a potential option to detect oral cavity cancer. Yes, it's correct. Saliva's direct contact with the lesion also makes it more specific and potentially sensitive to, whereas more than 100 salivary biomarkers have already been identified. Also, some Oryx DX has developed a tool also, but FDA has not approved. Further research is still required, sir, for the reliability and validation of salivary biomarkers for clinical application. Already we had a long presentation by a HOD, sir, from Tamil Nadu, and he said that, to my surprise, even 2.5 to 3 years before, we can diagnose common carcinoma using saliva assay tool. Really, it's a new surprising message for me. But still, it has not evolved, but it may evolve in near future.
Correct.
Okay.
Malhar, do you find any role for this in post-treatment surveillance for recurrence?
Sir, if there is a role, we all would be more than happy. But as of now, we should rely on sir's statement that the time will tell what will happen. But we are looking forward. If we get some test, we all will be very happy.
So the message throughout this is that visual inspection is still the cornerstone of diagnosing these pre-malignant and malignant lesions in the oral cavity. For difficult situations where you have less access to the oral cavity itself to examine the mucosa, you can use different aids, and to further define lesions more accurately, define their extent, you can use some other devices. But it all depends upon a good oral visual inspection. And that is why all of us who have a job of looking inside the mouth must train ourselves well to understand what different lesions look like, so that graphic image remains in our minds and we are able to pick these lesions early enough. I think we have covered most of this. The point of care diagnostics, basically what I was trying to hint at, and we had some reference in our earlier discussion, is that when we are talking about these handheld devices, Dr. Moni from Shaw Mazumdar, it was a collaborative study with UCLA, I believe, and other centers, where they use this device at a point of care. So it's a point of care microscopy to see whether it can give you a reliable results. But I believe the issues will be of cost effectiveness and the accuracy and so many other issues. So these are feasible, but may not be practicable on a widespread scale. If you have anything to add to that, we'll move on to the next one. So I'm concerned about the screening interval. If you look at the NCG, the National Cancer Grid recommendations, the screening by the specialist is recommended at 2 years. In the Kerala oral cancer screening trial, it was 3 years. But we know that these they do not have a very long pre-malignant phase, many of these cancers. And we have seen that our own patients who come up with a second cancer, they come up in between follow-up visits with a new lesion. So should we be looking at a shorter screening interval to be recommended to the government or anyone who engages in a population-based screening? Rajiv, would you comment on that?
Yeah, as you mentioned, like Kerala trial, they used 3 years interval, and but like Japanese program is there a screening program they use every year. So other areas as well, like as you mentioned, lot of these lesions are not just malignant transformation from the potentially malignant lesions, but they are de novo, like they are coming fresh. So most of these patients will be presenting with just 2-month history or 3-month history. So if your interval is so long, so obviously you are going to miss a lot of cases. So I think, but at the same time, you have to see your resources, infrastructures and logistics. So those things are also important. So ideally, in ideal setting, it should be less than 3 years. Ideally, it should be 1 year or so. And it should be every year. And age as determinant, in that case, so right now recommendation is 30 years and more. So because a lot of patients we see below 30 years and like kids, maybe the 14 years, 15 years old, they start using tobacco products. So after maybe 7 years or 8 years, they come up with oral cancer or potentially malignant lesion. So I think that age criteria that should be decreased to maybe around 20 years so that we can detect most of these patients with oral lesions.
Would most of my panelists agree with that? Dr. Sunil, Dr. Lalita? That we need to bring down, see the age in the NPCDCS, that's the government flagship program for detection. The age mentioned there is above 30 years, which I think is too late for our setting. And so far as the interval is concerned, I would like to draw a parallel. If you look at the American Cancer Society guidelines for cancer screening, it says that cancer screening should not be done as a separate activity, but it should be combined with an annual health checkup. That's one. The second is because oral cancer is not a very big issue for them. So they have not included oral cancer. They just do breast, colon, but it includes a good physical examination. So I think because we follow by and large the ACS guidelines for most other cancers, it's time that we adopted this in our own practice and follow an annual health checkup in which we must incorporate an oral examination.
Right. As we say, as dentists, we say biannual examination of the oral cavity for dental problems. So at the same time, we can advocate oral screening examination for oral cancer biannually. I am for that. And I also agree for your annual health checkup. When they go for an annual checkup, they'll go for a ECG, echo, and but they'll never think about the oral cavity. So it is it's mandatory for us to suggest this protocol.
Right.
I also agree with the madam. We have to implement at least twice in a week or thrice in a week. So we have to start these things at the college level, because most of the college students, particularly once they finish the schooling, so they are free of all the things, restrictions, what you have in the schools. So once you enter into the college life, definitely the tobacco habit starts. So we have to start from there itself at the college level and the individual colleges and the public sectors, etc. So that I think twice as a part of a oral screening, at least twice in a year. So that will be twice or thrice a year, so that we can, along with the diagnostic test also, that is also an important, so that we can have something awareness we can give it to the students particularly.
Thank you. Dr. Arul, would you suggest that patients or individuals who have already been diagnosed with an oral pre-malignant lesion, they need to be evaluated by certain other criteria than being clubbed with normal individuals and being screened at biennial or triennial intervals? Do they need maybe 6 monthly or that kind of a frequent assessment?
That patients with oral diagnosis, oral potentially malignant disorder should be treated. If they have stopped the habit, cessation of the habit really leads to most of the cases regression, or it may not progress. So definitely it has to be evaluated. First thing is they should stop the habit. Cessation of habit is a must. Only then that we can expect some positive results. If not, 100% definitely it will progress to the next stage of cancer.
Thank you.
Thank you, sir.
So we all agree that we must do our part about opportunistic screening, and there are certain things which the government and public authorities can do about population-based screening, like making it more frequent and maybe use of telemedicine to gain access for training and to collect data from the remote areas. Dr. Murthy, if you're still there, I think you are going to talk about this anyway, so we'll skip this. This is the last one. I was asked to talk about, cover this also. Probiota. So we know that we have an oral biome, just as we have an enterobiome, and basically all of epigenetics of what our genes are going to do is determined by these organisms which live inside us, with which we have a commensal kind of symbiotic relationship. We did look at some time back at oral cancer recurrence. In this study, majority 2/3 were actually second primary tumors. They occurred 3 years or later during the study in the study period. We found interestingly that poor oral hygiene and limited mouth opening were important predictors of these second cancers also. Is it because patients who have previously been treated by surgery and radiation, their oral flora are altered? Does this oral flora protect against cancer in normal individuals, and does it get disturbed, and that is why these patients are at a higher risk of developing second oral malignancies? I mean, these are some of the areas which all of you can comment upon, and we'll start with Malhar.
So Dr. Malhar had to go. He has left the.
Okay, so Rajiv, would you like to take up? Vishal is not here.
Yeah, so any prediction model that can predict your outcome, chances of recurrence, that will be always helpful. But in head and neck cancer, especially oral cancer, I don't see any prediction model that has validated in our practice. So if something comes out, that will be really helpful for our patient.
But I want your comment on probiota. I mean, do we need to work on that, try and modulate that for normal individuals, for those who have been previously treated?
So there are very few studies are there on probiota, and definitely Lactobacillus salivarius that has been found as beneficial for cancer inhibition, oral cancer decreasing risk. But as such, there is no clinical trial as. So all these studies are on cell lines or in vitro, in vivo or in vitro studies. So that has not come in the clinical practice for oral cancer. So till the time something concrete comes out, we can't say much about role of probiota for reducing the risk of oral cancer. So obviously, like good oral hygiene with good healthy diet, that will definitely reduce risk for any cancer in our body.
Thank you. Any Apurva, Dr. Arul, do you want to make a comment on that?
So actually, they are probiotics are friendly microbes, and lot of studies, as I said, we are reading a lot of articles that lacto-based salivarius ren has ability to inhibit development of oral cancer. So there can be potential inhibitory action against oral carcinogenesis. Also, they include tumor cell apoptosis, and they inhibit tumor cell proliferation and metastasis. So it's very surprising, sir. So we can give this particular micro capsule to all people who are taking tobacco and drinking alcohol. Also, with pre-malignant lesion, we can reduce that, sir.
That's interesting. Apurva, you want to say anything that Dr. Sunil?
No,
Any
sir.
last comments?
Sir,
No, sir.
regarding the limited mouth opening that occurs usually if it is a deep of ulcer, particularly in oral cavity, if it invades to the masticatory muscle, then only the opening will be limited. So that, of course, about the ulcerative conditions, not only thing, but poor oral hygiene, yes, I agree with that. That could be one of the marker in the precancerous cancer stage that might prediction, that could be prediction, or it may be aggravate. We can say that one of the predisposing factor. But limited opening, I think it is still, I cannot comment on that because it is after the occurrence of a lesion. Then if it invades very deeply, then only the patient will have a limited mouth opening.
Okay, so possibly,
possibly it could be. Yes.
This was based from Gujarat, which has a lot of OSMR.
Okay, yes,
so possibly these patients already had limited mouth opening.
Yeah. Thank you.
Thank you. So if there are no more comments, we'll close this session.
Definitely.
Thank you, all of you, chairpersons, my panelists, esteemed panelists, for giving your time, for staying back. This was supposed to be a 2-hour session today, and we started 1.5 hours late, over 1 hour late. Yes. So I'm very thankful, appreciate your patience, and appreciate your contribution. And thank you, Shruti, Dr. Reena, everyone, for having us all here.
Thank you, Reena and team, for this wonderful session and opportunity.
Thank you, madam. Thank you, Reena, ma'am, for giving opportunity. Thank you, Pawan, sir. Thank you, Dr. Durga, and everyone. Thank you so much, sir.
Thank you so much, everyone. I think we had a terrific scientific session and the panel discussion today.
It was amazing, amazing,
I
completely.
agree that we ran a little late, but I'm sure that all of us here enjoyed the session very much. I'm quickly sharing the quiz link. If there are any questions, I'll request everyone to please post it on the chat box. It's open for next 2 minutes, and I have also posted the link to the quiz competition. It will be open for 10 minutes now. So all of you can start taking the quiz right away. I am going to give the instructions as to how to do and go about it. So it is 6:54 p.m. So we'll stop right at 7:04 p.m. The quiz stops then. Okay. So I'll request everyone, please open the Google form. Ensure that you fill in the details and start the quiz very quickly. These are the schedules of the quiz. These are the the theme for the different Sundays. For today's, it is oral lesion treated right. We have a set of 20 questions which you have to answer, and these are the prizes which come your way. Everyone gets a participation certificate. The top 20 winners get scholarship for the Certified Tobacco Cessation Specialist Program. The first, second, and third have very huge scholarship of 50%, 40%, 30% respectively. The rest of the 17 participants get a 25% scholarship for their score. There is an opportunity for selection to full scholarship for the orientation program with tobacco cessation. And every day we're going to randomly choose 5 people from the list, and we are going to send Triscare as a gift to the members. These are the programs. I've just put it down on the slide for your short notice so that you can understand what these programs are. We have an advanced level certification, which is CTCS, for which you have been given different levels of scholarship. The orientation program, where you are given 100% scholarship to select participants who would be selected basis their score. Tobacco Marshal is open for all of the audiences who can join and participate. This is the link, ICanCaRe.in/academy. Join the ICanCaRe, the Gujarat University certificate courses in tobacco cessation. These are advanced level and intermediate level certifications. So the main sole purpose is to ensure that all of the individuals who take this program understand and learn clinical intervention. They understand what data-driven methodology needs to be followed at the clinic so that they can really perform succession and bring in a lot of success. These are now the instructions of the quiz. So I'm sorry, this is not second, this is third. So on the third, we're going to have 3 quizzes. Today is the first one. We're going to have next on 16th and the next on 23rd. So if in order to win the prizes, you have to participate in all the 3 quizzes. The scores and the total time would be taken together to find out the winners. The decision of the judges would be final. All the answers would be displayed on the community page and the E-Conclave website. The prizes and the certifications have been already told to you. The prizes, the organizers will get in touch with you so that you can, all of you can take your prizes in. Okay. We do not have the quiz master for the evening. He's already voted for his slide, so I'll be the quiz master for the evening on his behalf. So please fill in your the details, and there are multiple choice questions. So one answer is correct. So ensure that you answer it very correctly. Okay. So good luck to all of you. I'm going to quickly read the questionnaire for you so that it becomes easy. It is already 3 minutes past. I've shared the link. We have another 7 minutes to go. The question, here comes the first question. Pre-malignant lesion at highest risk of malignant transformation is a homogeneous leukoplakia, erythroplakia, non-homogeneous leukoplakia, oral lichen planus, or oral submucosal fibrosis. Question 2. Which risk factor is not associated with an increased risk of transformation of leukoplakia to cancer? The options are leukoplakia in non-smokers, homogeneous subtype, presence of dysplasia, less size than 2 centimeters. I'll request all of you to please refrain from answering on the chat box. Please only answer on the Google form. Do not put any answers on the chat box. The third question, which oral cancer subsite is associated with the highest rate of occult neck metastasis? The options are buccal mucosa, hard palate, oral tongue, lower gum, upper gum. The next question, after surgery or radiation therapy that could potentiate trismus, the following prophylactic therapeutic options could be considered: tongue depressors, massage, botulinum toxin type A injections, commercial devices, Triscare, and physiotherapy. Question number 5. The 2 most important factors predictive of local recurrence in cancer of the oral tongue are close positive margins and perineural invasion, close positive margins and grade, tumor thickness and close positive margins, T-stage tumor thickness, T-stage and close positive margins. Question 6. Which CT-based landmark differentiates level 3 from level 4? A hyoid bone, thyroid cartilage, cricoid cartilage, or tendon of the omohyoid muscle? Question 7. A 60-year-old male patient presents with a white patch in his floor of the mouth. You can make a provisional diagnosis of the leukoplakia. What is the significance of leukoplakia at this site? Increased risk of ankythosis, increased risk of dysplasia, marked hyperkeratosis, increased lymphocytic infiltration. It is 6 minutes past the quiz. We're going to stop in another 4 minutes. The next question, choose the correct sequence. The risk of malignant conversion of oral leukoplakias in decreasing order is a homogeneous verrucous speckled, verrucous homogeneous speckled, speckled homogeneous verrucous, or speckled verrucous homogeneous. Which of the following is not a PML condition? Oral lichen planus, OSMF, xeroderma pigmentosum, or cheilitis granulomatosa. Question 10. Presence of multiple pre-malignant lesions in oral cavity is aptly called as pre-malignant condition, field cancerization, immunocompromised, pre-malignant syndrome. Next question. Most accepted treatment modality for managing OPMD with dysplasia is observation, cryotherapy, surgical excision, photodynamic therapy. Question 12. Truth about verrucous carcinoma is it is exophytic. It may involve soft tissue and bone. Nodal metastases are rare, all of the above. Next question. In vital staining technique, using 2-nodine blue for detection of oral precancer and cancer, dash acid is used. Fill in that blank. 4% hydrochloric acid, 1% sulfuric acid, 1% acetic acid, or 10% formic acid. Next question. Which of the following statements is false regarding marginal mandibulectomy? Option 1, dependent on the vertical height of the body of the mandible, contraindicated in the edentulous patient, may require a fixation plate, unsafe in the irradiated mandible, contraindicated is thank you, ma'am. Contraindicated if the tumor is through the cortical bone. Next question. Which of the following investigative procedures is gold standard for achieving the diagnosis in case of oral leukoplakia? Culodine blue staining, brush biopsy, cytosmear biopsy. Next question. Which of the following is an antioxidant that is used in the chemoprevention of the oral cancer? Iron, bleomycin, methotrexate, selenium. Third last question of the evening. Resection of cancers of more than 1/3 of the oral tongue are best managed by primary closure, skin graft, alloderm graft, free radial forearm flap, secondary intention. A simple method to clinically differentiate white patch, such as leukoplakia and candidiasis, is by scraping the lesion, spraying the lesion with topical anesthesia, probing the lesion, or none of the above. Next question. A chronic inflammatory disease of the oral basal epithelium mediated by T cells is the definition of erythroplakia, oral lichen planus, leukoplakia, or PVL. Last question, ladies and gentlemen of the evening. Narrow band imaging is based on identifying in oral lesions, dash oral lesions, so you fill the blank, basement membrane, intracapillary loops, dysplastic cells, keratin. There are certain set of compulsory questions which you have to answer. Would you practice oral screening and tobacco counseling in your routine after this workshop? Yes, no. I would like to start an ICanCaRe Tobacco Wellness and Oral Screening Center. I want to get trained in tobacco intervention. Second question, TrisCare, the innovative mouth opening device for Christmas care made of POM material, which is unbreakable, gives sturdy mouth opening, can measure the grading and improvement of mouth opening. You would like to order the same for your patient. So here are your options. Please contact me. I want to order. I want it available in my hospital pharmacy. I'll ask my patients. No, I prefer my old age methodology. So that's it. We are at the end of the quiz. I'm sure that all of you must have also finished answering the question. We still have a minute to go before we close the quiz responses. All the answers would be available on the community page. You have been a lovely audience, I must say. And let me reiterate this information that is compulsory to participate in all the 3 quizzes on all 3 Sundays to ensure that you get the scholarship. These are the prizes once again. You get a certificate from the organizing committee, scholarship for the orientation program and the CTCS, the advanced certificate program. Lucky winners get TrisCare for free, and there's an opportunity to get 100% scholarship for the OCTC program. This is where ICanCaRe is striving to build capacity in succession and ensure that we are preventing cancer at the very nascent stage. At the early stage, we are detecting it through oral screening and through ensuring that we are taking the right procedures at place. We are thankful to Gujarat University for really helping us and researching and devising the structured curriculum to make it a data-driven and an evidence-based procedure intervention methodology. These are the certificates which you get once you finish the program with us. There'll be a participation certification for all our participants on this E-Conclave, on all the social media and also on Zoom. I would request participants who are on Facebook and YouTube to please ensure that you put down in comments your email address or send a message to the ICanCaRe the ICanCaRe message on Facebook with your email address so that we are aware that yes, you have been there at this session. This is the TrisCare mouth opening device. 5 lucky participants from the audience today are going to get this. This has been researched and thoroughly designed by ICanCaRe team in collaboration with Gujarat University to ensure that mouth opening becomes easy. This device is very sturdy, handy, and can be used for easy rehabilitation and jaw motion rehab. Okay, that's it for the day, ladies and gentlemen. I think we have had a wonderful time. I'm going to give all our participants 2 minutes to interact with all of us, and then I think probably we can stop the session, stop the meeting for the day. Anybody would like to share any comments or compliments or give a feedback? This is open. Please unmute yourself and share your comments and feedback and compliments with us. Thank you. Nothing. I think, ma'am, we are overwhelmed with 4 hours of program. It's 4.5 hours. I think I'll leave the last words to you.
So thank you so very much for being a fantastic audience, because the yearning and the learning requirement and everybody wants to be involved in this gives us so much of happiness and so much of motivation. And I cannot thank enough to our esteemed faculty, our domain specialists, the chairpersons, the moderators, and of course, Dr. Durga, who has carried the program through. And Shruti, who is the heart of it all, who just holds everything together. So Dr. Somesh, thank you so very much. Like your inputs and everything that you have helped us with and borne and taken the brunt with us. I know that you've had a busy day today, and we are extremely sorry to have kind of delayed you from your next assignment. But I think the panel discussion was so amazing that it kind of took all of us, however tired we are, we couldn't leave our seats at all. So thank you so very much, everybody. If I missed anybody, thanking anybody, it was only inadvertently. But most importantly, thanks to all our guests and all our participants. Let's meet again next Sunday, same time, same link. Let's come back again. Thank you so much. Yes,
Reena
yes,
ma'am,
Durga,
Shruti, and everybody, thank you so much for giving me this opportunity. I had a lovely time. I thoroughly enjoyed myself.
Thank you, Durga. Thank you so much.
Thank you so much.
So have a lovely
Bye,
Easter
ma'am.
evening and a family time, everybody. Thank you so much for spending this great time with us. Goodbye and good night.
Bye.
Thank you so much, everyone. I'm closing the meeting link. Have a great
Photograph.
Sunday. We'll see you again next Sunday at the same time at 3 p.m. with another terrific discussion and quiz competition and students presentation coming forward to your place. Thank you.